Welcome everybody and good morning. This is a meeting of the Leicestershire, Leicester and Rutland Health Overview and Scrutiny Committee, which we tend to call joint HOSC among us. It's being held online, and if you don't catch it live, it will be archived so you can watch it at a subsequent time. My name's Kevin Feltham. I'm a Leicestershire County Councillor representing the Gartree Division, and I am chairman of this joint scrutiny committee at the moment. The meeting is being broadcast, and as I said, it's on YouTube. So if you'd like to watch it, it is there, or watch it later after the meeting. Can I firstly ask that participants in the meeting try and avoid using the Microsoft Teams chat facility, because obviously the public can't see that, and it also helps keep comments apart the meeting so the public can take part and see what's happening, unless you obviously have a technical problem, in which case please do that. And also, can I ask that all officers and members mute their microphones until they wish to or are invited to speak. When you're speaking, please make sure your video is turned on as well, so people can see our pretty faces. And now I'll go around effectively like a roll call, just to make sure everyone can hear and we can hear you, and to introduce yourselves. I'm aware that John Coxon is substituting for Jonathan Morgan, and I know there are a number of apologies being sent in by the city, but what I don't know is how many of them have got any substitutes, but we'll see. I'll start off with Councillor Aldred. Are you here? No. No mention. Councillor Chamond. No. Mr. Coxon. I've seen him. I know he's around. I was talking to him only 5 minutes ago. John? No. He was having trouble even then. But hopefully he'll join us. Councillor Fonseca. Mrs. Hack, I've seen you.
I can see Kevin, you. Thank you. I'm here and I can hear and everything. Thank you.
Councillor Harvey, I've seen you as well. I know you're there.
Good morning, Kevin. Yes, I'm here.
Thanks very much. Councillor Dr. Hill.
Yeah, I'm here, Chair. Can see and hear everybody. Thank you.
Councillor Kittrick has sent his apologies. Councillor March. Shame. Mr. Awesome, I've seen you. I can see you.
Yeah, Kevin.
Councillor Mrs. Page. Oh, again, another one that was with us. We had a group meeting about 5 minutes ago. Where she's got to. And Mr. Parton. Yes, I can see you.
Good morning, everybody.
Councillor Mrs. Sangster. This is a pattern building up here, isn't there? I've seen you, Gail. So Councillor Weller. Yes, I've seen you.
Waller.
Indeed. Sorry. Yes, it is. Gosh.
I know.
I've just had new specs as well. And the next person I know has sent apologies in, which is Councillor Paul Westley. He sent his apologies anyway. And we also have Health Watch, Janet Underwood. I've seen you. And I thought we were going to have Mukesh Barrow, but I see you're the departure.
Good morning.
Excellent. I can see you.
Yeah.
Never quite, had you? Hello there. Yes.
Chair, sorry, I've just had a message from Councillor March, and she's been struggling with her IT since 9:15.
Oh, yeah.
So I don't know whether or not the city are having updates on all their tech, because obviously the city colleagues haven't joined us. So I wonder if there is a technical problem.
Yes. Just as a response to that, thank you very much, Amanda. Because the city had their, they call it Health and Wellbeing Scrutiny Commission meeting on Wednesday night, on which at least two of the items we're discussing were also on their agenda, particularly the UHL finance situation. And Councillor Kittrick, Councillor Sangster, and particularly Councillor March played quite a big part in that. I listened to it last night. I was hoping they'd still come and join us today, but maybe, as you say, maybe they've got a problem. I noticed all their meetings are on Zoom. They don't use Teams, so maybe there's that as well. Although they've joined us before, so well, there's that as well. Anyway, welcome everybody. Our first item on the agenda is actually, it seems strange to be asking about minutes of a meeting that we held back in September, but the last meeting we had was actually in December, and it was because it was quite quick turnaround, we didn't have time, or the officers didn't, to have to sort out the minutes of the 23rd of September. So we still need to approve those. So I propose that the minutes of the meeting held on the 23rd of September are taken as read, confirmed and signed. Agreed? Question mark. People generally nodding. That's lovely, thank you very much. And then item 2 is minutes of the December meeting we did hold in December on the 14th. And I propose that the minutes of the meeting held on the 14th of December are taken as read, confirmed and signed. Is that agreed? General nods and waves and things. Thank you very much.
Chair.
Yes, hello.
Apologies, Chair. I just have one thing to bring up on the December minutes regarding a question that I put in. Unfortunately, the last part of that question hasn't been answered. There was an answer to be given by the 23rd of December.
Yes.
So I was wondering whether that would be able to be chased up, please.
Yes. No, thank you, Sam. No, I was aware of that problem. I was going to talk about it actually.
Oh, sorry. Thank you.
No, fine. Well, thank you for doing it. That was about the babies and things, wasn't it? Ewan and I spoke about it only yesterday, and he said he's going to chase it again, because all the others have been supplementaries as well, have all been answered. So one way or another. So it is important, I think, we get an answer for you as well. Yeah, we'll chase that for you. That definitely needs doing. Thank you, Sam.
Thank you.
Item 3 is question time. I've really received no questions from the public, at least not within the relevant timescales. Item 4, questions asked by members. I've also received no specific questions from members. Item 5, urgent items. I've not been notified of any urgent items. Item 6, declaration of interest. Does anybody have any interest they wish to declare? Oh, good. Melissa's joined us. Welcome, Melissa.
Apologies for being late, Chair. I had some horrid IT issues this morning.
Chair, I should just point out I do some paid employment for a mental health charity in Leicester.
Yeah, thanks very much. Thanks. Just to let you know, Melissa, you appear to be the only member from the city who is joining us.
Okay, thank you for letting me know.
Glutton for punishment, clearly. I did listen to your meeting from Wednesday night.
I know this agenda is a bit of a deja vu, so apologies to health colleagues as well.
I know, it doesn't help, does it?
Sorry, can I just check regards Mr. Parton?
Yes.
Is there a particular agenda item you're declaring an interest in, Mr. Parton?
No, there's none. There's none. There may be. I was doing that as a purely precautionary measure.
Right.
So you're not declaring an interest in any particular agenda item?
I'm not.
Okay. Thanks, Ted. So item 7, presentation of petitions. Not received any petitions today. So we now move on to the first substantive item, which is a system update, winter pressures review and NHS 111 first, which on our pack is on pages 41 to 56. And we've got Andy Williams, I've seen, Rebecca Brown, Acting Chief Executive, and also Caroline Trevithick is around. And I see Mark Whiteman's there as well. Gosh, definitely gluttons for punishment. So I leave it to whoever is going to lead us on this.
Thank you very much. We've got several colleagues. I think Tamsin's.
Yes, I've just seen
Tamsin's here as well, and I think Tamsin, if I've understood this correctly, Tamsin, I think you're presenting it through the pack. Is that right?
Yes, that's right. So yeah, Councillor Feltham.
I just wanted to check with you before I kind of dumped you on that and make sure that was okay.
That's the sole reason I'm here.
Okay, so just to kind of say a word of introduction, Chair, we've got a partnership-based approach which includes colleagues from local government and other partners as well, meets and has met all the way through the winter process. We called the Health Economy Strategic Coordination Group. Tamsin's been coordinating a pile of work with colleagues on our response to all sorts of pressures that we've had, of course, including the winter pressures, and this report just provides an overview. So Tamsin's going to lead us through it, and then obviously we're very happy to pick up any kind of questions between us that might arise. So Tamsin, over to you.
Okay, thank you. So as Andy says, the winter plans for this year were very much overseen by the health economy strategic coordinating group, but and a subgroup of that, the urgent and emergency care group. And as you know, we plan for winter seasonally every year. This winter was probably a winter like no other. So in addition to planning for the expected normal seasonal illnesses, we had the complexities of preparing for additional COVID outbreaks. And indeed, that did materialise right in the thick of winter over December and January. Also had to take into account the impact of COVID on staffing, both absences and staff shielding and not able to undertake operational duties. Preparing for the expected mobilisation of the vaccine programme just immediately before Christmas, again coinciding with the winter peaks, and also reflecting the impact on operational service delivery and the way that services have had to change the whole way that they care for patients to keep them safe from COVID by, in essence, separating clinical treatment areas out into COVID and non-COVID areas, which has an impact on capacity. And that, added to the need to kind of don and doff PPE, etc., does have a really significant impact on overall throughput through clinical areas, particularly in ED, which has been separated into effectively 2 EDs to keep staff and patients safe through COVID. Added to that, very acutely aware of the impact of the COVID pandemic on overall bed utilisation and the impact on elective care, and I'll come to that towards the end of the report. So the key elements of our plan for this year were essentially to combine managing the COVID response with preparing for the winter surge, and we, within that, had to restore quite a lot of the capacity that in the first wave of COVID we had closed down, but also balance that with a real shift towards non-face-to-face consultations wherever that was clinically appropriate and keep patients safe. We are operating a number of what we call COVID hot clinics and services, not in ED, but in primary care facilities as well, and they maintained through the COVID period, plus screening patients, both walk-in patients and patients coming in on ambulances before arrival at clinical areas, so we could keep patients safe and direct them into the right COVID or non-COVID service. We brought on a number of new services to prepare for winter, so we delivered the 111 First initiative, which I'll talk about a bit later in the report. We really upped our game on emission avoidance and clinical support to both ambulance crews and GPs to keep patients safe in their normal area of residence. And that's been a real success story for us this year, with consultant-led conversations and in-depth assessments of patients before they come to the ED. We also carried out a successful flu vaccination programme this year, and I think one of the unexpected benefits of COVID essentially has been that we have had fewer seasonal illnesses than we normally would, partly because the flu campaign's been successful, but also because social distancing has reduced the rate of infection in the community, and that has helped to offset some of the pressures we experienced through COVID. So the paper, which I'll take as read, goes into some more detail about the things that we put in place, including additional bed capacity in both University Hospitals of Leicester and Leicester Partnership Trust. And I'll just concentrate on the key impact, essentially, and how well our services have fared. I think the highlight message was that partnership working across the health and care system has been really robust and strong and helped us to get through this collectively, despite the challenges that we faced. And overall, the Leicester, Leicestershire and Rutland emergency care and urgent care system has coped remarkably well in the face of the challenges we faced. We were assisted in that by lower attendances at ED, at emergency department and urgent care services, partly as a result of COVID keeping people away from face-to-face services and a big shift towards calling 111 and using non-face-to-face consultations, but also, as I said earlier, because the rate of normal seasonal infections was actually lower this year, and also the rate of some injuries reduced as people were not engaging in their normal activities, reduced road traffic accidents and reduced minor injuries as well. So you can see from the graphs in the report that our ED activity declined really steeply from January to April was the low point, April 2020. And although it rose again through the summer months when COVID was at its lowest, it's still running at about 75% of our pre-COVID levels. And that has helped to counteract the reduction in capacity that has taken place in operational services as a result of them having to deal with COVID and non-COVID streams. So that has assisted. Demand on ambulances has not dropped in the same way as the emergency department. The number of calls to EMAS and EMAS, what they call incidents, has remained at similar levels to the previous winter. However, what we have seen is a really significant reduction in the number of EMAS calls that then result in a conveyance to the emergency department, and that is and our system is the lowest system in the East Midlands in terms of the number of ambulances that have to take people to ED. That's a real testament to the partnership working that we've done and a number of initiatives that we've got with EMAS to support them to directly access other services and to manage people working with primary care and community services to keep them well at home. And that has really helped to take the pressure off the emergency department. But also we've seen a really significant drop in the number of times when we're seeing long ambulance waits outside the emergency department. Historically, that's been a real concern for us as a system, and you can see from the graph in the reports that despite the fact that in January the number of ambulances attending Leicester Royal Infirmary emergency department was actually slightly higher than in the previous January, the days on which we had significant waits over the 15-minute target is dramatically reduced. And as a system, I think we've become more resilient. So when pressures do build up as a result of pressures on hospital beds or space within the ED, we regain operational resilience much quicker. And that is a result of some really excellent partnership working between the ambulance service and university hospitals of Leicester, as well as the strength of our community services. Over December and January of the Christmas and New Year period, we saw that the 4-hour wait target was at 66% compared to 63% the Christmas before, which is a key kind of marker of how well that flow is going through the emergency department and the impact on patients. So while that is significantly below the national target and what we'd expect to see, it was an improvement on last year. And I think we had to balance the impact on operational capacity, as I said, with the numbers of patients coming through. So I think in summary, I would say that it's been a really challenging winter, extremely challenging for staff in keeping services operating during the COVID pandemic. But by a number of key markers of emergency flow, we've done better than in previous years. However, that said, we have seen really significant numbers of planned and elective patient procedures put on hold during the pandemic, and the key challenge for us as a system as we come out of COVID is now to restore capacity to see those patients and reduce long waits. That's not the subject of my report particularly, but you will no doubt have it in your sites and want assurance about it. The paper summarises that UHL are undertaking harm reviews in all their clinical specialties and now bringing on plans to bring back patient elective care, prioritising the most clinically serious. And that work is happening at pace now as we start to come out of the worst period of the COVID pressures and obviously coming out of winter as well. So I'll stop there before I move on to one first and allow you to ask questions. I can see a number of hands have gone up.
Yep, that's lovely. Thank you very much, Tamsin. I'll reserve any of my questions. I'll let others ask them first. Ted Parton.
Thank you very much. So the first question I've got, and thank you very much for that report, it's understood just how much pressure you've been under. Something that would help is that if you imagine somebody reading this report who has not worked for the NHS, what they would see, Tamsin, is they would see lots of groups. So there's the LLR, there's the emergency care group, there are economy strategic coordinating group and supporting subgroup, the urgent care group. So could we have, please, a flowchart of who these groups are and how they work together and who feeds into who and who feeds off who? Because that is something that, I mean, any workforce, I'm sure if you looked at the armed forces, there would be all sorts of different groups. And it's the same in local councils with senior management teams. But attempting to understand all these different groups and how they all work together, system escalation levels led by the CCG-UEC team. So it would be interesting to understand how the whole organogram works together. So that would be one thing I would request, please. Now, obviously, we'd have to speak to the chair when that would be produced, whether that's for another meeting or whether that can be provided in between meetings. So the next thing is let me just go to the most important things. The one thing I did want to talk about, and I want to make it clear, because this is going to seem like a criticism. It's going to seem like I've found the one thing I can pick fault in. That's what it's going to seem like. But you seem to have struggled with an IT issue, because on page 51 at point 24, it says, this was enabled despite the lack of a national IT solution. And then if you move to point 27, it says, in particular, to resolve IT issues that were preventing patients being booked into appointments with their own GP practice. So the question for that department in the NHS is, you're working hard in possibly your most difficult winter since the last pandemic in, was it in the 1920s. So what's the reason that? What are the reasons that they weren't ready to support you when they've had all year to see that this was coming in the winter?
Okay, so just in respect of your first question about an organogram about the different incident response groups that stood up in the pandemic and their relation to the urgent emergency care group that led on winter planning. Absolutely, I have such a flowchart. It's not a problem. I can get that through to you and by today, and I can provide more detail on that if helpful at a future meeting as well. So that's absolutely fine, and you know, if that level of detail is wanted, we've got that. In respect of the IT issues, I think you skipped to the second part of the report that I haven't talked through yet, and I'm happy not to go into detail about the rest of the report because if people have taken it as read, but that's relating to the changes we made to the 111 system to do what's called 111 first. There is now a national system for booking patients into emergency departments. There wasn't when we went ahead with our local changes, and we were one of the first systems in the country to implement direct booking from 111 into the emergency department. We managed to do that with our existing IT capability because we have for a number of years been working really hard on our 111 system and its interoperability with our urgent care services. So we were able to enable that direct booking without that national system. That national system actually was implemented in the LRI emergency department yesterday at 4 o'clock. So some sort of 5 months after we went live, and I think that just shows the level of progress that we've made locally, and one of the reasons we were chosen as an early implementer. The issue relating to booking into primary care was essentially not a very significant issue, I think, but it's one of these incidences where systems have been updated over the years and pathways haven't been retested. So we'd enabled direct booking into GP appointments a number of years ago, but lots of GP surgeries had refreshed their IT systems and those pathways had been affected by that. And we didn't realise that that was being compromised until we started to look at the 111 first project. We then identified that problem and put it right. So I hope that gives you some assurance reassurance that IT is always an important part of any significant project, and not without its glitches. But I wanted to highlight the areas where we have been successful despite IT challenges.
Yeah, thank you very much. So I know you said you're going to then talk about 111 again. So do you want me to save the question, Chair, about unheralded attendances at ED until Tamsin's spoken?
Tamsin, it's really down to you. I mean, how much were you going to go into more detail?
Well, I mean, I'm as much detail as people would find. You've got the report. I hope it's clear and easy to understand. So I'm happy to not talk to it and instead just concentrate answering your questions, unless anyone particularly wants me to summarise the key points. Happy to just answer questions.
Oh, great, thank you. Well, it's regarding the this on page 50, the key deliverables aim for 20% of unheralded attendances. It does then talk on the next page about there was reduced activity, but sorry, I do apologise. It's on page 53, point 36. There has been a decrease in the number of unheralded patients. So obviously your key performance indicator that you were aiming for was for 20%.
And
what figure did you get to in the end?
Well, it fluctuates week on week, but you can see from that graph that we have exceeded the 20% reduction that we were aiming for in every single week. I haven't worked out the latest average, but it is below it's below the 20% target. I mean, it's rather we've exceeded the 20% reduction.
Oh, that's good then. Yeah. Excellent. Thank you. Thank you very much for answering all the questions.
Thanks, Ted. You can put your hand down now. Gail Waller.
Thank you, Chairman. I've got a couple of questions and a comment. If the answer to my questions is in the charts, please forgive me, but they're too small for me to see them because of my sight problems. So I'm going to ask them anyway. The first one is relating to the reductions of admissions to the emergency departments. When we were talking back in the summer of last year, this was a concern to our colleagues in health because they felt some people who should be turning up weren't. And we were all urged to encourage our residents to go if they felt they needed to, COVID notwithstanding. Is this still a concern, is my first question. And then when you've answered that, somebody's answered that, I'll move on to my second.
Yeah. So you're absolutely right. In the very early period of the pandemic, when we saw that very dramatic drop in attendances, there was genuine concern that people who clinically needed to be in the emergency department weren't there. You'll see, well, you can't see the charts clearly, and I apologise for that. But since that very low point, emergency department attendances have risen again. What's happened within that is that the case mix, the mix of presenting complaints is different to before COVID. So the numbers of patients who we will call majors, the seriously ill patients, is actually much nearer to the pre-COVID levels. What still is below COVID levels is the number of what we call the walk-in patients, the minor illnesses, and some of the minor injuries. And that we think is clinically reflective of the changes we've made to services. So you'll see from the report that we're doing much more clinical assessment non-face-to-face. But also in relation to injuries, the rates of injuries has gone down because people are much less active now, people's normal kind of sporting activities, the risky behaviours around, too much alcohol consumption that lead to, people having accidents or fights leading to their ED attendances. All of those have significantly changed. So we feel that the clinical presentations now are much more reflective of the level of serious illness in the community, and some of that minor illness that doesn't need to come to ED is not coming now, which is appropriate.
Thank you. That's very encouraging, I think. So I guess you'll get more once people start playing football and cricket and stuff.
Well, and in fact, at the time of writing the report, all the data in there is accurate. But in the last 2 weeks, we have seen a really significant spike up in emergency department attends. We had a 10% increase in 1 week last week. And within that, also an increase in some of the injuries. So we are starting to see a worrying concern to sort of the previous activity. So we'll be responding to that with an enhanced communication campaign about using 111 first, and also doing all the things we're already doing around trying to divert people into more appropriate non-emergency department settings. But we can expect people to start to behave a little bit more like they did pre-COVID as the vaccination programme leads to more confidence and things like that. So we all need to counter that going forward.
Okay. My second question relates actually to paragraph 13. You write about the initiatives you've put in place to support EMAS, and you spoke about them as well, Tamsin. Are you going to continue those after this is all over, as it were?
Yes. So absolutely. So the two key things that we have done to support EMAS, the first is actually transferring low acuity ambulance calls from the EMAS, what they call their stack. So when calls are waiting to be dealt with by EMAS, those are now being automatically transferred, the low acuity ones, into our clinical navigation hub that's run by Derbyshire Health United. And that has had really significant positive impact on the number of ambulances that then get sent to ED because they're clinically triage assessed, the relevant treatment responses put in place, and 75% of those cases then do not get an ambulance response where they previously would have. We are going to mainstream that service now. It's been seen as an example of good practice, and it's being shared with other regional colleagues. And the other thing that we've done that has been very successful, and we plan to extend going into the coming year, is the consultant-led support to EMAS crews when they're on scene to help them to compose and action the right care plan for individuals who may be very frail actually and poorly, but won't benefit from a trip into the emergency department. We started doing that just with care homes in the beginning of the pandemic, and we've extended that during the winter period now to make it available to patients living in their own home, and it's having fantastic results. So 80 to 90% of patients, when that consultant advice is sought, are being supported not to go into the emergency department and be admitted to hospital, and that's a huge benefit for them, and it has a really good impact on the system. So we'll be mainstreaming that service with an increase to clinical capacity to support that going forward.
That sounds really good news. It's nice to see something good coming out of a crisis, isn't it? So thank you for that, Tamsin. And my third point is actually just a comment, and it's really for the chairman. There's in the section on 111, there's reference to an evaluation happening of it at some point in the future, whenever that is the right time. And I just wondered if we as a committee could see that evaluation when it's done, please.
Yeah, no, I'm sure. I'm sure Tamsin will be only delighted to let us have a copy of that. And
Thank you.
Yeah, thanks very much, Gail. I just let repeat that we've got 4 people on the question list. There's Sarah Hill next, Amanda Hack, Melissa March, and then Rosita Page. I think we'll draw a line under it at that point. Sarah.
Thank you, Chair. It's interesting, these sort of crises, want a better expression, do accelerate a lot of things that have taken a long time to come. I was having this conversation with somebody in the street the other day. One of my questions, a lot of my points have already been addressed, so I won't bother going over them again, but sort of I was interested in your opinion, Tasmin, if anecdotally, getting to see your GP is like getting to see the Pope. In fact, probably it's easier to see the Pope these days. So are you seeing that reflected in ED attendances? Are people coming in who really should have been seeing their GP, but they've ended up with you because it's easier, they were told to go there, yada, yada, yada? I mean, I'm interested in your view as to whether this is an urban myth or not, really.
Yeah. So what I would say is that during the COVID pandemic, we are actually seeing less people that should have seen their GP than we were previous, but that is still an issue. I think GPs have responded to the COVID pandemic just as acute services have, by trying to change from face-to-face consultations and treatment as far as possible to non-face-to-face, and so the way that people are accessing primary care has changed fundamentally, and I don't think we'll ever go back to fully to the previous levels of face-to-face contact. But obviously that is something that's difficult always for people to understand and or accept, and so there are still instances when the public are arriving at ED and feeding back to the ED team that they haven't been able to see their GP or not been able to see their GP face to face. So we're responding to that in a number of ways. We have previously had GPs embedded in the emergency department, and in the inception of the COVID response, we took those GPs out of ED and located them in a primary care hub called Westcoats in the city. So we are, if there are patients who do really need to see their own GP, we either contact their GP and get them seen by their own practice, or we can get them seen by a GP not in the emergency department same day, and that is enabling us to kind of get that activity out of the emergency department where it doesn't belong. Yeah,
that's lovely. Thanks very much. That's it. Just shows you, doesn't it, how different. I mean, I'm as an aside, really, I don't necessarily need to see my GP, but I do need to see nurses to take blood out of me for various reasons. And I've not had any of the blood removed from me at all for a year. And then right out the blue, I was wondering how to get it sorted. I've rung several times. They just said, wait. And I had a phone call, and now I've had my blood taken out. But clearly, it's not just the effect of GPs, it's also nurses and everything else. So it's that side as well. Amanda.
Thank you, Kevin. It was just a couple of points, if I may, Tamsin. Colleagues have already covered most of it. On paragraph 15, you identify that there's been priority 1 surgeries taking place. And obviously other surgeries will have to be timed in at some point in the future. Could you talk to us about the impact that has on other services in terms of wraparound, health and social care, and any connection to that would be really helpful. The second point is there isn't anything in the paper with regards to the impact COVID has had on your staffing. And how the staff management throughout the winter I'm sure will have been incredibly challenging. So a little bit of a flavour on that would be really helpful. And that's it. Thank you.
Yeah. So the report wasn't primarily aimed at discussing the impact on elective care, but it's really important to note that during the pandemic, and particularly in December and January, the number of patients that were getting planned procedures had to be put on hold significantly. Some of that was taken up by the independent sector. We've really increased the use of the independent sector as partners, really, in our system to manage some of those cases where it's clinically appropriate. So some activity has been going through there, but there are significant numbers of patients who have had to wait for their procedures, and they'll be being brought in for care over the coming months. That will have an impact on service. Obviously, it will have an impact on occupancy rates during and use of acute sites, but also, as you say, some of the supporting services such as reablement services, etc. And actually, one of the things that we really noticed in the beginning of the pandemic was the drop in reablement. And on investigating that, some of that it was to do with the fact that actually a lot of those patients are patients that have had elective procedures, as well as, you know, the frail elderly type interventions. So we can expect those services to become busier as we come out of the pandemic, but actually we have been actively trying to get more patients through to things like reablement services in the last 6 months anyway.
Can I come in about the elective plan? Because I think it's probably important, an area and something that we all as a system are taking very seriously. So we know that, as in the first wave, there was an impact on all patients waiting electives. That's all the way from cancer all the way to the most simplest operations. And it's very important, as we did in wave 1, that we have a plan to put that restoration and recovery in place as soon as possible. and we absolutely will phase that around cancer first, as we did in wave 1, and then we would look to the other patients. We have a 6-week programme that we have, and we are in the process of rolling that out, which will really see that the ramping up of activity as soon as the ITU, particularly the ITU capacity, will allow. Because remember, our ITU is being cared for, the patients in ITU are being cared for not only by ITU staff, but by theatre staff and other staff to support, because of the numbers being so great. So we have a plan. We've already started some of that work around cardiac cases and cancer cases, and we will roll it out, and we will make sure we work tirelessly to support that position until we get to a position where all our cancers dates are in place. The key issue is around staffing, and I think you did raise that, and I think we have to recognise this winter, whilst there has been some fantastic work, and particularly the work around emission avoidance, attendance avoidance that this system has worked on together, we know that this winter has been very, very difficult, and it means that our staff have been pushed and pushed and pushed to deliver care in environments without the full numbers of staff that they would have, except the sickness levels have been very high, COVID levels have been high. So that care for our staff is a key element that the system are working to, again, collectively. We've got a wonderful mental health hub that we've put in place, that we are going to have in place to support our staff and to absolutely bring down those sickness rates, which you can see are really dropping as we come out of the crisis.
Yeah, thanks for that, Rebecca.
Kevin, could I just add a little follow-in, if you may, please? In terms of the elective procedures, the kind of things I'm, obviously the other things that I'm thinking about is delayed hip, delayed knee replacements, and the impact that then has on the delay in terms of increased physiotherapy, and how is that being planned for? I mean, obviously, cancer patients would definitely need to take that priority, but I'm thinking about those surgeries that prevent further requirements for treatment, and how will that be managed within the system?
Yeah, a really, really good question. So once we've done the initial 6 weeks and rolled out to make sure those the most urgent, life-threatening treatments are done, we then continue to roll out until we get to a position that we have got all our theatres running and everything back in place that should be, recognising that we now have a COVID world that we will always have. So from an infection control point of view, things will be slightly different. So we will get to a position where we will be fully functioning as a trust, but I think that will probably give us around 85% activity of what it was in the past. So as Tamsin says, it's using the private sector in a different way, which we are, again, very successful as a system to work with, but we'll be pushing and driving that further. And then we need to have a recovery programme that will probably be a 2-year programme. It won't be a quick programme. I think we have to be frank and honest about that. And what we need to make sure that we have in place is, one, that we have regular checks and around those patients waiting, just to make sure that they've got proper support in the community, but also recognising that, we've done years. If you think that the NHS has had a year where it's worked in a very different way, to catch up that year's worth of activity will probably take us a number of years. So we need to be transparent with that plan. We need to be honest about what is achievable and what isn't achievable, and we will be able to really focus on that once we've got the real urgent patients through and treated. And again, we won't be doing it on our own. We'll be doing this within the region, with nationally. We'll be looking to support each other. Because one of the other things that, if you think this winter has been one of the toughest winters ever on record, we've also been supporting not only our own COVID cases, but we've been supporting, because of our ECMO service, nationally and also regionally for our ITU. So we supported London, because they didn't manage with the numbers that they had. They needed that mutual support. So we've not just supported our own community, we've been supporting other communities as well with their most poorly patients.
Gosh.
Thank you. Thank you, Rebecca.
I think probably also just worth saying that Leicestershire Partnership Trust and social care services are part of that restoration plan, and to an extent some of the capacity that they have had to redeploy to manage the COVID response is now being brought back into supporting that restoration plan. But as Rebecca says, it will take months and years to work through all of that.
Of course. Thank you very much. And now the last question actually is from Melissa.
Thank you, Chair. And it's less of a question. Everyone will be pleased to know, I'm sure. So it's more just that I have a caring responsibility for one of the people we'd consider a frequent flyer, a very frail, very elderly grandma of mine, and that during this period, I've kind of seen firsthand some of those specialist ambulance crews and all sorts of other things, and just how amazing that was, and how much effort everybody was putting in on the ground to keep her at home. And then when she was admitted, there was it feels really brutal not being able to visit at the moment as a carer, as somebody who loves somebody who's in an ITU or the frailty unit or on a ward, whoever you are, and the way in which staff bent over backwards to make it possible for me and other family members to communicate really was so effective and so reassuring at a really tricky time. And I know I'm not alone in that. So just to put that on record and to say thank you to everybody for that, and that what your paper and my experience are really chime well about how effective our NHS has been during those unprecedented pressures. So thank you.
Yeah, thank you very much. Yes, thanks for that, Melissa. Yes, I think it's a point well made. I thought we had finished, but in fact, Rosita Page has come back on the list. Rosita.
My questions have all been answered, other than one thing which just occurred to me. And by the way, thank you very much for that comprehensive report and question and answering session. With less non-face-to-face contact, where GPs and everybody picks up underlying issues, mental health or probably dementia or whatever, do you feel that those things can be missed and in future add to the pressures, and how is that being featured in your new planning ahead? And thank you.
Yeah. So I think that is obviously a concern of clinical teams, that in the necessary shift to not seeing patients face to face at the beginning of the pandemic, that some of the underlying needs in their patients might be missed. But I think that clinicians have put a huge amount of time and thought into transforming the way that they work. So triage systems and clinical triage in primary care by doctors to try and get a sense of the presentation and whether the patient needs to be seen face to face. I think our GP practice has done a tremendous job to really change the way they work, including bringing video consultations on and different ways of trying to get a more holistic view of those patient needs. And the feedback from practices is that in many instances, they're actually spending more time with individuals and able to do a more in-depth review because they're not seeing so many people face to face, and that in some instances they've actually been able to identify the need to intervene and be able to keep people well at home with a care plan. In instances when they were absolutely frantic in clinic, they may have passed that patient to the ambulance service, for instance. So in some instances, it's had really positive benefits in terms of how primary care have been able to engage with people. But there are clearly concerns that for some individuals, they may not be accessing care in the way they need to. So I don't know, Caroline, I don't want to put you on the spot here, but in terms of any reflections you would offer about the way that clinical services are responding to that as we come out of the pandemic. If Caroline heard that question.
Can you repeat the question? Sorry, Tamsin, I was.
The question was really around in the shift to non-face-to-face consultations. Although GP practices have responded to that fantastically well and used technologies like video conferencing, etc., is there a risk that for some individuals their clinical needs are not being appropriately identified?
Yeah, absolutely. And some of the work that we're trying to think through in terms of the recovery that Rebecca was talking about is how we assess harm, because we know that we've got hidden harm, we've got potential harm for people on waiting lists, but more importantly, we've got harm for people who haven't been presenting. So that becomes a big part of our challenge for the recovery and restoration work that we need to undertake going forward. It's difficult to quantify what that might be, but we know that it's happening because we know from feedback from patients that people just haven't been presenting, and we know from our data as well, where we're looking at some of our performance data where we're achieving potentially some of our cancer 2-week wait targets. It may be because we've got a hidden backlog of people that just haven't come forward. So I think that may be something that you want to explore with us as we go through the next few months as to how we are addressing and, well, first of all assessing, but secondly and most importantly addressing any harm that's been identified as a result of this.
Yeah, thank you very much. Thanks, Caroline. Yes, that was very useful. Thanks, Tamsin and Rebecca and Caroline. I think we've had a good report there. Obviously, hopefully a unique time that we won't have a repeat of this next year. I think from my point of view, the very fact that the flu numbers have dropped like a stone, maybe that's just the example of the fact that we're all now keeping 2 meters apart and we're wearing masks and all the rest of it. If that's the case, great, but hopefully we don't have to keep doing that for the rest of our lives. But I think it really is absolutely incredible that NHS clearly what first 111 first is clearly working, but yes, let's encourage more people to use it. I think that's a key message, isn't it? And also I think the fact that we've had, I mean, people talk about particularly the really acute stuff and things like cancer and so on, but there are all other sorts of matters in the background. And I made that example earlier about my blood test. That might have found something 6 months ago, which would have been effectively is only now being identified, and so on. So it's going to roll on, I know, but I think we've had a good discussion on it today. And I say I thank you to all the presenters. I think that was very good. And the questioners. So we move on then to item 9, which is Caroline again, and it looks like Andy's around. This is the COVID-19 vaccination programme. Now, what I would like to say is that I know the city covered this a lot on Wednesday. I heard it all and watched it, and this is joint. So I'd like it to be covering, hopefully, the whole of LLR, because obviously the city had a good go at it on Wednesday. Okay, over to Caroline.
Thank you, Chair. So given the fact that the last joint HOSC was in the middle of December, this is the first report that you've had on the vaccination programme. So it does kind of take us back a few weeks. And this is a programme that has been progressing rapidly over 8-9 weeks that we've been working through the programme. So there is a bit of retrospective stuff to bring people up to speed because it's a public meeting, but I've got some up-to-date data that I want to share with you as well, because of course it moves on a daily basis and some of these figures are out of date. So in terms of what the report talks about, it shows you where the vaccination sites are. We've got 19 that are GP-led, either in GP practices or in borough council, district council buildings. So fantastic support from partners in getting sites set up. But also our vaccination centre is in the People Centre in Leicester City. We've also set up hospital hubs. University Hospitals of Leicester and Leicestershire Partnership Trust have stepped up to the ask and put in place hospital hubs, and we've currently got 3 pharmacies so we've now got 5 pharmacists. I'll tell you, it changes on a daily basis, that are delivering services, and we're working with NHS England to ensure that we've got pharmacies coming online where we need them. So we've got some maps there. The vaccination cohorts are being led by the work of the joint Committee on Vaccinations and Immunisations, or JCVI, and the evidence that they've looked at, the clinical evidence that they've looked at, has resulted in the cohorts being grouped as they are. And the view from JCVI is that those cohorts represent about 99% of preventable mortality. And so working through those cohorts on a national vaccination programme has been the central tenet of the vaccination programme. And we're currently up to cohort 7. We'll be releasing cohort 8 next week, and hopefully cohort 9 as we go into the later weeks in March, with the aim to vaccinate all of those people by middle of April, and that's, you know, an absolute huge undertaking going forward. The data that we have released is changing again on a daily basis. The access to data, as NHS England become more confident with the accuracy of the data, they are absolutely releasing more and more. As a vaccination team, we've had access to primary care level data at PCN level, but also some of the equality data to ensure that we can drill down into specific areas of concern where uptake is lowest, and that's kind of really important that we do that. So our headline figure on the 14th of February, when this report was done, was 255,000, and we're now, our data up to the end of last week was 376,000. So as you can see, you know, we're absolutely cracking on through the doses. The other area of focus that we've been picking up on, as well as the additional cohorts, is to make sure that we're going into houses to pick up housebound patients. We don't want housebound patients and people who've been shielding to come into communal areas. So our GPs are definitely working to get through those patients. One of the constraining factors has been vaccine supply, and as a system, our ambition, our ability to deliver these vaccines has been very much controlled on vaccine supply. Our local ambition and targets have been greater than the supply, and we wanted to do that so that if the changes to vaccine supply happened and we got more vaccine than we're expected, we'd got the infrastructure in place to be able to respond to any increased supply that we were able to get hold of. But supply is based on the industry manufacturing the vaccine, but also is based on ensuring that we've got equity across the country, not just in STP sites. And people will know at the moment there's been lots of talk about the fact that it's feeling a little bit quiet at the moment on the vaccination front, and that's purely due to the fact that we've got that supply has reduced. But our planning tells us that in the next couple of weeks that's going to double again, and we're going to ramp back up. And so our planning has been matched accordingly. Some of the cohorts are focused on staff vaccinations, and we've been working really closely with partners and about 600 employers across LLR to ensure that we've got names of people who are eligible for vaccine, who are staff, whether they're working in health or social care, or the wider primary care teams such as community pharmacists, dentists and optometrists. So we've been focusing on ensuring that we are picking up staff vaccines, and also from a city perspective, particularly some real positive outreach work with our partner agencies, local authority and the charities, to support our homeless population. We're picking that work up with the district council as well, where we know we've got homeless populations, particularly in Loughborough, because concern about that. our areas of concern around vaccine take-up, I'm going to list them because we've got 5 in the city, 3 in the county and 3 in Rutland. And as Councillor Feltman said, we had a bit of a deep dive on these city areas. But for completeness, areas of concern in the city: St Matthews, Spinney Hill, Northfield, Crown Hills and St Saviour's. In the county, North West Leicestershire, Charnwood and Thorpe Astley, and in Rutland, Market, Overton, Cottesmore and Empingham. So our data that we're looking at really does allow us to get into those wards to think about to see what the uptake is, and also look at it by deprivation and by ethnic group. And we're really lucky to have Viv Robbins from Mike's team, public health team, to lead the piece of work on inequalities and vaccine hesitancy. And they're doing it, as you would expect public health to do, from a real scientific approach, looking at confidence, convenience and complacency as influences on vaccine hesitancy. And I could do a whole presentation on just exactly what we're doing to address those. But it's a mixture of comms and engagement, direct contact with patients, taking the vaccine out to specific groups with pop-up clinics, women-only clinics. We've hijacked the Loros bus to take that out to the travelling families, and also to support people where we've got faith leaders and supporting our faith leaders in going out into those communities on our behalf. So there's a whole range of actions that we're undertaking as a result of that, and we can definitely get that information to you because it's being shaped and worked up as we go through. We've picked up some specific work with the district councils in the county, particularly yesterday. Where we're looking to see how the district councils might help us specifically with some of those populations as well. So we're really focusing this on from a system approach to trying to raise the profile and increase the uptake where we know we've got low uptake. Our comms and engagement plan is absolutely massive, and we are trying to max out the number of people that we can speak to, particularly trying to address some of the concerns that people have got in terms of efficacy, long-term impact of the vaccine, and trying to resolve some of the fears that are coming through with those. So fact sheets, Facebook Live, Twitter, all sorts of different events have taken place. So we're still progressing. Our next steps, as I say, is to get cohorts 1 to 9 vaccinated by the middle of April. Phase 2 then is for the over 40s, and then we will be also then thinking about what's happening with boosters. Overlaid onto all of that is second doses, and because of course it's not just a single dose like the flu vaccine, we're planning for second doses, and it's really important that our comms and engagement plan ensures that people do come forward for their second doses, because the first dose is important, but the second dose is just as important, and we are really trying to ensure that people will come forward there. So I'll stop there for comments and questions, and if that's okay, Councillor Felton.
Thanks very much, Caroline. Yeah, as one of the world leaders in getting the vaccine, of course, back in August, when I took part in the trial, it all seems very old hat to me, and I just can't understand why people don't go for it, which I keep telling everybody didn't do me any harm. Ted.
Thank you very much for this. One thing that certainly for reputationally to protect the NHS is that, for example, in Loughborough, the Charnwood vaccination centre, which is in my division, has been shut a week, and it's by two main roads, and of course, it's very public facing that people just think. Every day they drive past and the doors are shut. Yeah. What can we do to almost when these centres are shut to almost put a notice to say why they're shut? Because, you know, it's obviously going, there's a lot of public debate, especially on social media, and it's not helpful for your reputation, considering how well you're doing. That's the first question. It's regrettable to see today on the BBC that it's reading the article, it was almost like it was just an attempt to find fault, but there's this debate today in the BBC about some people with asthma aren't getting the criteria is unclear, but I got the impression that was almost a little bit of the BBC trying to be over scrutinise it, and again, it's not helpful. But what is the reason that the supply has almost ground to a halt at the moment, and when will we see that supply coming up? For example, there's a vaccine from America by Moderna. When will that be arriving in the UK, and what other ones, especially the single dose jab from Johnson & Johnson? You know, what's the sort of timetable? Because obviously if we don't know on this committee, then certainly the public aren't going to know, and for them all they see is they drive past Charnwood and see it shut every day. I'm thinking of your reputation. Yeah.
Absolutely, Councillor Parton, and thank you for those questions. The issue around closed vaccination centres is something that we're working with NHS England on to try and get some messages out. If I'm speaking fairly bluntly, NHS England want to manage the message around vaccine availability. So we've been relatively constrained in terms of what we can say locally. We are trying to work through our partners in the Borough Council. Apologies, my dogs are going to start barking because there's someone outside. So that we are working with our partners, and they are putting messages out on our behalf. Unfortunately, they're not as strong as we would like, but we're working on that one. And I hope you can see through my response there that it is something that we are locally concerned about, but we have little ability to manage it at the moment. That will change, though, because, yes, that will change because in answer to your question about supply, the supply is absolutely going to be doubling over the next 2 weeks, and so we will be back to full strength, and those vaccination centres will be open, and it is purely based on manufacturing availability. So you know, it is being used as quickly as people can manufacture it, and so you know. It's a hiatus that we're trying to work through. It will get better. The Moderna, while I'm talking about different vaccines, Moderna is the only one I can talk about because I don't know the dates for anything else, but they're talking about spring. So it could be any time now for the Moderna vaccine to come online. And I think it's important that I pick up the asthma question, because it was something that was definitely raised through one of our Facebook Live events. In some ways, it's a really positive message for people with asthma. The fact that the evidence is now telling us that people with stable asthma aren't being as adversely affected by COVID disease as was first thought. And so the people who are being focused for vaccination who have asthma are the people with unstable asthma who've needed hospitalisation or who've needed steroid therapy, and that's tablet steroid therapy and not inhalers. And that was an important message to get out to people, I think. I'm an asthmatic, and I was a little cross at first, but actually reassured that it's evidence-based, the fact that I'm not on the list yet for a vaccination, and so I'll wait my turn but be reassured with the fact that I'm a stable asthmatic, so that's positive.
Oh, that's very helpful, actually. I mean, obviously, I've had my vaccine because I was a volunteer, but as part of that, I had to own up to all sorts of diseases and what was wrong with me, and asthma was one of them, diabetes and so on. And still I was jabbed. So obviously at that point I'm a volunteer, just get on with it. But it is interesting, as you say, the stable asthmatic, sounds like you're the same as I am. But it's the other side. It shows that they're now getting so much more information, and therefore they can begin to differentiate between all these various aspects. Is where we're at now. A year ago, well, I gather it was a year ago that the first case was found in Leicestershire, and look where we are now. 77,000 cases later.
I remember that day well.
Yes, quite. Amanda.
Thank you, Kevin. A couple of questions, if I may. Item on point 7, it talks about adult carers, and it's been raised to us via constituents, as well as being in the national press, about eligibility for carers, because quite often the eligibility is limited to those who get a carer's allowance, but we know that family care quite often will be provided by more than one carer. So can you talk a little bit about how you are ensuring that carers that don't get a carer's allowance are still eligible for the vaccine, and how that is being organised, because I'd be really grateful for that. And apologies, if I could declare an interest, please. My second question is about progress for those individuals who've been identified with having learning disabilities, and the to get some kind of reassurance that Leicestershire is accessing those individuals and getting the vaccine to those individuals, particularly linked to the comment on homelessness, because a lot of people who live in learning disability accommodation actually also live in HMOs. So they are sharing accommodation, and I think that's a really important one. And finally, from a vaccine point of view, the 3 areas that you've identified, Thorpe Astley, whilst I'm not the county councillor for Thorpe Astley, it is my town division. So anything the town council can do to get the message out. Frustratingly, we've got the vaccination hub in Thorpe Astley. So anything we can do, I'm happy to take a conversation offline on that, please. Please let me know.
Thank you, Councillor. I'll take that back. In terms of carers, we've, in addition to the carers receiving attendance allowance, carers who are registered with a GP are being contacted by GPs. And some of our comms has been to try and encourage people to register as carers, because that does help. We're always encouraging people to register as carers, irrespective of this. And it has, one of the added bonuses is that GPs have been overwhelmed by people putting themselves forward as carers, which is a great outcome, actually. So that's one way, because it allows GPs to make contact with people, but also people who are contacting the vaccination centres and declaring themselves as carers, then they are being vaccinated. You know, we are trying to get into that population. From an LD perspective, anybody on an LD register in primary care is being contacted through primary care. But in addition, the Partnership Trust has put on specific LD clinics that have got slightly longer sessions to allow people to come in with their carers and be vaccinated. And the care home cohort, that was cohort 1, that was focused on adults, but we're now doing all care homes, and so GPs are going into care homes to do the LD population. We pushed that quite early on locally, because it was our LD programme boards both wrote to me and said we want to have a process in place for that. And so we've been doing that for quite some time now. Interestingly, some of the GPs have been contacting me to say, can we put the LPT clinic in contact with the GPs, because they've been contacting people with LD and they're not 3 or 4 times and they're still not coming forward. So we're having another think about how we might work a little differently together to address that uptake in that population.
Yeah, thanks very much for that. Rosita, and I bet you're going to talk about Fielding Palmer.
How did you guess? Besides that, I must say congratulations to the reports. You always take the wind out of my sail by giving such a comprehensive update. Two questions. Firstly, because as you can imagine, I'm inundated with questions. Why has a lot of money been spent on the Fielding Palmer and it's now laying dormant and there's no activity? So I don't know, was it for everybody? Just talk me through that. And that's parochial. And my second question is more because you're talking about second doses, but what are your thoughts for the future? How are the programs going to be? Will it be like the flu where we're going to just talk me through those thoughts a little bit? And thank you again.
Thank you, Councillor Page. The answer to Fielding Palmer is the same as Councillor Parton's question about Charnwood. At the moment, it's because of vaccine availability. So we just haven't got anyone to book in there at the moment. But Fielding Palmer has got the Primary Care Network and Leicester Partnership Trust working out of there. So we have plans to start it up again when we get the vaccine through. We are thinking actually that the numbers coming through Fielding Palmer may mean that the Primary Care Network need to take it over completely because of the modelling that we're doing. So it may be that in the next few weeks the Partnership Trust step away and just allow the Partnership Trust to deliver vaccines from there. But it is classed as a really important site for our delivery locally. And the second one on boosters, I'm not really best placed to answer this because I'm not familiar with the discussions that are happening about this. I know discussions are happening, but there are all sorts of questions about boosters. Will it be 6 monthly? Will it be annually? Will we be able to combine it with the flu vaccine? I've got more questions than answers myself at the moment, Councillor Page, and it may be that that next time I come that we'll have so much more learning that we'll be able to understand what that means. But we're only just starting the second doses for the majority of people in the last week or so. So we've got a few months to consider what that means, and that's going to be led nationally. It's not a local decision. So we will do what we're asked, and we'll share the information as soon as we get it.
That's good enough for me. And if I can please be kept in the loop over Fielding Palmer, so I can reply to all of the residents who keep nagging me. Thank you very much, and good luck.
Gail, you're next.
Thank you, Chairman. I've got 2 or 3 things I want to raise. The first is, it's in relation to paragraph 15 in the report. It's about fake messaging. And I'm assuming that was the message that we all saw, or a lot of us saw on various Facebooks saying, oh, if you want the jab, go to X. Is that right?
Yes, it's been difficult in terms of the national booking system. As the national booking system came online, we had to put our own messaging out around something called Swift Queue. So Swift Queue is something that we are in control of. It's our local booking system that we've got in place that we had before the national booking system. But the main thing around fake messaging is where we've got information that is saying things about the vaccine that is untrue. Right. Sorry, the dogs are off again. What we're trying to make sure is that any message that goes out is accompanied with an NHS logo now. So either the CCGs or one of the trusts, to ensure that people realise that is coming from us. The fake messaging tends to not have that. It's more the Facebook stuff, and it's not. You can't trace it back to any of the NHS websites.
Okay, thank you. That clarifies for me. I would like to say that you are not going to get your message out to everybody. Well, I don't like to say it, but I am going to say it. And that's inevitable because not everybody's looking at your websites, etc., etc. Certainly, here in Rutland, and I'm sure it's almost certainly true in Leicestershire and probably in Leicester City, there are a number of community websites that we as councillors are plugged into. And I'm sure if you asked our chief execs or your major contact in our authorities to ask us to put your message on our community web, Facebook, Nextdoor, or whatever one we're on that we have in our areas, that we'd be more than happy to do that for you. And I think that might help get out or counter the fake news. And well, is that okay? Yeah. And while I'm on that particular topic of communication, Sam Harvey and I were both concerned when you mentioned the areas in Rutland where you were concerned about the take-up, because we thought take-up in Rutland was quite good. And why we were particularly concerned is, coincidentally, it was villages within our 2 wards. Our wards go beyond that, but it just happened to be that. So our first question is Stockton Prison a significant factor in it? And secondly, whether it is or not, are there any other issues that we can use our networks locally to target?
Yeah, so that's the piece of work that Viv Robbins from Mike Sandy's team is working on now. The issue for Rutland is it's lower in comparison to uptake everywhere else. So we're comparing it with other uptake in Rutland. So Rutland has got a really high uptake when you compare it to the city as a whole, but there are some areas that we want to delve into in Rutland. So I don't know the reasons, because the data is hot off the press this week, but Viv is leading that work locally with the local teams to understand exactly what it means. So we've got those 11 areas across LLR that we're doing specific pieces of work, and we will absolutely come out to partners to make sure that we're working together to get underneath that. So I can't answer in full, Councillor Waller, at the moment, but rest assured, as soon as we know what the specific issue is for the specific village or area or whatever it is, we'll get out there and come and talk to you.
Fine, thank you for that. Moving on then. Hold on, find my note. The staff vaccinations, there is a reference in paragraph 10 that, well, the implication is that you want a greater take-up in staff. Is there a concern at all amongst staff that they might have a reaction, however mild, because a lot of us have had a reaction, albeit mild, that meant we needed to take the next day off work, and their employers would be resistant to that? Has that been a concern at all?
That hasn't come through. The majority of concerns that has come through from staff have been relating to fertility and pregnancy. It's those concerns that have been doing. In terms of our aim for staff vaccination, it's exactly the same aim as we've got everywhere else. It's 100% uptake. That's what we're aiming for. The uptake now has gone up from that 75% to 85%. So again, in a couple of weeks, it has changed. And just in the same way as we're doing for populations, we're looking at the data around staff hesitancy. And a conversation we had this morning kind of demonstrated the benefits of one-to-one conversations, because what might be worrying me may not be worrying a colleague. And so trying to get underneath that and really address those specific problems is something that our HR teams in health and social care are all working on to try and resolve. But it is more associated with that fertility issue with staff.
Okay, thank you. And that leads me very neatly into my last comment when you say one-to-one helps. I was very impressed with the idea of those who aren't being vaccinated getting a call from their GP.
Yeah.
I think that, we heard about it on the radio as well and on television, and I think that's just excellent. So well done.
Yeah, thank you. I shall feed that back to the teams concerned.
Yeah, thanks very much for that, Gail. No, I totally agree with you. I've got 3 more people I want to ask questions. There's Melissa March next, then Sarah Hill, and then Janet Underwood, and we'll call it a day at that, I think. Melissa.
Thank you, Chair. Just to share with county colleagues who and Rutland who weren't watching that meeting on Wednesday, there are some particular issues in parts of Leicester where less than 70% of over 70s have been vaccinated. But I'm not going to talk about that here. But that was the main thrust of our meeting on Wednesday. And my questions, I've got three, and they're so the first one, Caroline, is about frontline social care staff, and I know that rightly you're talking about vaccine hesitancy, but have we got any data about vaccine refusal in that cohort of people, and does the data, I guess, allow us to kind of break that down on the basis of profession and occupation? The second question is, at what point do we think that we could do that really important piece of work around vaccinating key workers, particularly teaching and policing staff, with any kind of spare capacity or vaccines looking to be wasted? Because it just seems a travesty that there are people who are, by virtue of their public service, in harm's way, but also there are people, there is some wastage. I know it's not a lot, but it seems we could, how do we marry that up? And then the third thing, Chair, tongue-in-cheek declaration of interest here from me, as in I'm talking, I noticed you mentioned the under 40s and I guess that some of the stuff that I have heard in around vaccine hesitancy is around fertility, and I guess that concern is going to rocket, and it's a myth that we really need to get on top of quickly before we get to that point at which we are starting to look at vaccinating that cohort, because under 40s, not exclusively, but that is where those two issues coincide. So any update about plans there? Okay.
So in terms of vaccine refusal, not yet, because that's the one-to-ones, that's the HR conversations that need to have. At the moment, they've been offered it and offered and offered and offered. We keep doing it, and they are self-selecting not to come for whatever reason. So we're doing those focus groups with people. So we're focusing on the hesitancy, which is important because we can get, that's our next low-hanging fruit, isn't it? They're those people who are hesitant, but those vaccine refusals, and to be honest, there's a national debate happening about what happens with people who refuse, who are working particularly in healthcare. There's always been a bit of a debate about that from a flu perspective, and so. We're trying to we're using the carrots at the moment. We don't want to use the sticks, and try and support people to allay fears and focus on that approach rather than anything else. The key workers. I'm going to.
Sorry, Caroline. Just I appreciate that, and I guess the numbers and the stats and our access to health workers is my question. Was social care workers?
It's health and social care. The stats are health and
but given the fluid nature sometimes in agencies and elsewhere of social care staff, I guess, does the data allow us to kind of dissect it on the basis of that profession really understand? Yes. Okay, lovely, thank you.
Yes, definitely. We've got it dissected by trust staff, by GP, other primary care, and then social care staff, etc., care home staff. So we've got all sorts of different breakdowns there. In terms of key workers, I have to give you the NHS position, which is the fact that the JCVI list is focused on age, and so therefore age is the risk factor here. And I'll take you back to the fact that it will reduce 99% of mortality. So that is the position around teachers and police, etc., fire brigade. Where we know, though, that we've got teachers, police and fire brigade that are classed as frontline health workers because they're doing certain tasks that puts them into that category, we're working with our partners to make sure that they're vaccinated appropriately. So we're trying to manage our way through the rules on that one. And did you have a third question? Oh, the under 40s, yes. Interestingly, on the regional Flu and COVID board yesterday, we debated again the issue of fertility and the myth busting, and we've been doing it locally. We've had one of our obstetricians do some work for us around trying to address the myths with that. It's been done on a regional footprint, but we're escalating it to the national team, because you're absolutely right. We know the hesitancy is going to come in and it's going to escalate with the young women and young men, I think, you know, from a fertility perspective, because we know that men is a category on its own that are resistant to picking up the vaccine. So so we know it's coming, and we're trying to identify ways to address that and do that myth busting.
Just sorry, Chair, just my final thing on this is, I guess there's again another intersection, isn't there, between kind of health and social care staff who are refusing that, and you know, particularly social care staff and that fertility myth because of the age at which they're at and the time of life in which they're at, and that perhaps if that's accounting for that 15% of people who still haven't taken up the repeated offer, then when we get into that cohort, we're going to see quite an acceleration of that percentage, and that should alarm us. Yeah,
it should. Yes, yeah, and is doing already. So yes.
Yes, thank you for that. Clearly, they missed that when they did my medical investigation before I had my my COVID vaccine back in August. I wasn't asked about my fertility, and I've not been tested on it ever since.
Well, you don't look a day over 41, Chair.
It just wasn't on the questionnaire. Sarah Hill.
Thank you, Chair. I think the issue of fertility myths, and also people being, a friend of mine who's been told by two sons and a sort of friend of his, complete, I was going to swear then, myths is the polite way I put it, off social media about the second dose. And, you know, I got quite shirty with this friend on the phone and was quite rude to him, because I just thought, how can you be so stupid? Also, I volunteer at the local medical centre, being run over by the happy patients coming to have their COVID jabs, and I can say they are getting learning disabled people. Definitely, they're you know, because people are recognised in the queue, so they are getting, back to Amanda's point from earlier, they are getting the jab and they are getting in. So I think it can be challenging at times, but that's the nature of the learning disability. My concern is around the second dose, because, you know, you said that the vaccine levels locally are going to double next week. Well, given that around the corner have got half their usual dose, if it's doubling back to normal, how are we going to do the second doses? I have this concern that, you know, there isn't going to be enough supply, and everybody needs their second dose who were done earlier on, and you're still trying to do the original cohorts. So that's one area of real concern I've got. It's probably a national issue as much as a local one, but, you know, I'm not getting much reassurance that there's double the amount of vaccine coming down the track. And then finally, I can see us, and I'm interested in your opinion, are we going to end up with a national booster service, or a local booster service that just does this? Because otherwise, you have 2 days a week where the GP surgery does nothing else but that, and it's not a good use of resources. So I'd be interested in your thoughts on that. Thank you.
Yeah, thanks, Councillor Hill. In terms of the availability for second dose, all of the planning assumptions that we've seen from NHS England do indicate that we're going to have enough to do first and second doses, and they've plotted that over the next 6 weeks. So the planning assumptions are there. So we'll see. Yes, absolutely. We'll see what happens. To date, they've been pretty accurate, actually, in terms of what they've said we're getting. We have got, and sometimes we've got more than we were expecting. So that's always a bonus. But that's as a system level. Some areas, you know, it's been swings and roundabouts. But as a system, we've definitely got what we expected. In terms of the booster, what happens with that? We are currently putting together as a CCG a proposal document about what might this look like. The missing bit of information that with that is the question that I couldn't answer for Councillor Page around what's the booster going to look like. But this is going to be with us for some years, and so having a properly commissioned service that does this. I think our concern at the moment, we've done this in a really, really short space of time. We're going to have to think about how we elongate it over a year. So, flu campaign is within a few months, but something like this, where it's the majority of the population, it's going to have to be dealt with differently. So these are all of the things that we're trying to work through at the moment, because we can see it coming just as you can.
Thanks very much, Caroline. And finally, Janet Underwood.
Thank you, Chair. Thank you, Caroline. I would just like to say for the people of Rutland that the vaccination service over here looks to be running very smoothly. So I was quite surprised to hear that we've got 3 problem areas. Surprised and concerned. What I'm wondering is, I think, I might be wrong, but I think that the vaccination appointments are being drawn off GP registered patient lists. And what I'm wondering is there some of the known issue of poor take-up due to the fact that quite a lot of people in Rutland particularly cross out of LLR boundaries into other counties for their primary and secondary care? And is this a distortion in the data rather than a poor update? Do you have sight of people that are going out of LLR for their primary care and are getting vaccinated out of area?
So our data is based on people who are registered with a local GP. So that's if they're registered with another GP in Stamford or somewhere like that, then they will be picked up by those. So it should equal itself out, actually, Janet, in terms of that. But it's back to my response to Councillor Waller. It's in relation to uptake across the whole of Rutland, and that kind of demonstrates that Rutland is quite a high uptake, but we've got areas that aren't as high as others. So if we compared them with the city, they're still way, way higher than the city. It's just they're different in comparison to their peers in Rutland. So that's why we want to get underneath that. Yes, we're focusing on people are being called who are registered with GPs, but people can also just book online irrespective of where they go. So all of the national messaging is if you're eligible for a vaccine, just use this. I Google it on a regular basis just to check when I'm eligible, and they can just put their NHS number in or their date of birth in, and they can access it that way anyway. So people don't have to go through their GP service. They can do it on the national booking system as well.
Could I just pick up on that point, please, Chair? We're very parochial out here in Rutland. Leicester is a long way away for us to go for the vaccination centres. I'm still wondering whether there are Rutland residents who are crossing over into Stamford or Grantham.
So the national booking system offers you booking in areas up to 45 minutes away from your home postcode. So if I give you my example, I was looking on the other day, and I'll give you my uncle's example, who lives just outside Rutland, and he booked onto the national booking system, and he got an appointment in Grantham because that was geographically better located for him, and he chose that out of a number on the list that came up. So that's irrespective of, that's based on your home postcode rather than where you're registered with a GP. So that gives you the ability to do that. We're not expecting people from Rutland necessarily to come into the city unless they choose to.
But it still hasn't answered my question. Does your data show Rutland residents who have their vaccination outside of the LLR region?
Yes, so if they're registered with a Rutland GP, no, because they're not in our responsibility, but they'll be picked up in the CCG, whose responsibility their GP sits in. So from a national perspective, they will be monitored, but not from our perspective.
Thank you.
Okay, sorry if I didn't quite get that.
Yeah, this is the trouble, isn't it? We're all divided up into little areas, and there's boundaries. Well, terrible, isn't it?
Can I just say something, please, Chairman, on that? Just to reassure Janet, I think it's, again, coincidentally, the areas in Rutland that are relatively low in Rutland terms actually have GP surgeries within them. And as a consequence, I suspect that most of the local people are actually registered within Rutland in those circumstances.
Area, yes. Well, one of the areas I have relatives living in, and I can tell you they've all been vaccinated at my sort of age, so I know that one worked. Yes, thank you very much indeed, Caroline. That's very, very, very detailed, and we've got a huge amount of information, especially with all the questions and things. So thanks for the questions as well. Very helpful. So thank you very much. We'll move on then to our final report, which is on pages 65 to 88 of your pack. And that relates to University Hospital Leicester NHS Trust audit. I have down Rebecca Brown and Simon Lazarus. I can see you're online, and I think Mark's around as well to pick up any questions. So I leave it with you. Thank you very much.
Yes, thank you, Chair. And in the context of all that we have been doing, which has been wonderful over the last 12 months, of course, one of the things that was a great concern to us at the hospital was the discovery of the challenge that we faced of this, unprecedented issue with our accountancy. This is a situation that I want to go through in three lots, if that's okay. So yep. Mark is here, who'll just talk us through the timeline of this, because I think it's really important for people to understand how we got to this situation. I will talk about what we've done about it, and because we've been working on this for at least 6 months now. And Simon Lazarus, who is our Chief Finance Officer and has been the key person putting right the technical actions on this, can answer any of those real technical issues, etc. So if that's okay, Chair, I'm going to hand over to Mark. But just before I do that, I do want people to recognise how very seriously this trust has taken this very, very challenging situation. And as many of you know, there are the majority of those, well, in fact, all of those that were involved in chairing or managing the finance in the organisation are no longer with us. So the chair of the finance and committee are no longer with us. The chair of the audit committee is no longer with us. The chief financial officer and their deputy are no longer with us. We also know, of course, that this last week our chairman has resigned, and let's put that into context of 50 very, very strong years of public service and amazing service for Leicester for the last 7 years. But I do want to just be clear with people that the challenge of this situation has been taken very seriously by the organisation. Okay, so over to Mark first, please.
Thanks, Rebecca. Yeah. There we go. Thanks, Mark.
Hello, Chair. Good morning, councillors. Chair, I'm conscious Sarah's got her hand up just before I come in.
No, this is for Kevin at the end. You carry on.
Oh, I'm so sorry. Okay, all right.
There was another hand a minute ago.
All right, I'm just going to whiz you through a chain of events, and I think the reason Rebecca's asked me to do it is because I'm not a financier, and so maybe I'll set it out in kind of layman's language. So the start reality is essentially we haven't signed off our 2019-20 accounts because the board have decided that they can't say they are true and fair, and for the avoidance of doubt, that's a very serious breach of regulations, both in the NHS or in a private limited company. The genesis of all this started back when we were doing the 2018-19 accounts, and although they were signed off as unqualified, in brackets that means a clean audit, there were some issues that the external auditor raised with us, which didn't hit the materiality threshold. Materiality threshold is essentially a percentage of your overall turnover. So for us, on £1 billion turnover, the issues that were raised amounted to some 15 or 16 million. They were significant enough that the then external auditor briefed the board on it. And as a consequence of that, the board and the audit committee expected the then chief financial officer to look into those issues and come back to the audit committee and report back on them. And on a number of occasions that didn't happen, and the then chief financial officer left the trust in October of 2019. That prompted the then chair of the audit committee and to raise this with the chairman and our then chief executive, John Adler, who you recall, and he asked our interim chief financial officer, who is now our full-time chief financial officer on this call, Simon Lazarus, to look into these concerns. And that's what Simon duly did. And I'll let Simon speak for himself, but what he found I don't think was particularly pretty. This was what was in the public domain and briefed to stakeholders, including yourselves, last January, and was essentially around a prior year adjustment that we had to make to the previous year's accounts, because the previous year's accounts had been misstated to the tune of somewhere in the region of £46 million. Between January of last year and now, that work that Simon Lazarus, our new chief financial officer, and his team did then has continued, along with the work of our external auditor, to get under the skin of what had been happening in terms of our balance sheets and financial statements. And that ultimately has uncovered more issues, which led to the board decision in December of last year that they couldn't sign off the accounts. As a consequence of this, the trust has been put into financial special measures, which is a regime. It does what it says on the tin, but it's a regime imposed by the regulator. And on balance, that's a good thing, because along with financial special measures comes a whole heap of external resource from other parts of the NHS to help with the finances, the management, the governance, and the reporting. And given our finance department is clearly beleaguered and not fit for purpose, that is a welcome intervention. And on the subject of team, as Rebecca has already mentioned, there have been significant changes in the last few months, not least that essentially just over a third of the executive board and the non-execs have left the trust, and all those people who had finance either in their portfolio or as an oversight have left. And just for openness, we know that some of our previous colleagues are now being investigated on the fit and proper persons test, and also being referred to their professional bodies. At a national level, the Auditor General, so the Auditor in Chief for the National Audit Office, has unequivocally said that although he considers the failures to be linked to the previous management regime, I know that people will draw their own conclusions, and that might be something that this committee wants to get into. I will say this, and Rebecca is going to shout at me afterwards for this, but for my part, I think Rebecca personally has played a blinder in the last year, because she has not only tried to hold the trust together as our acting chief executive and navigated the trust through stormy waters in terms of pandemic and our response to pandemic, and now our response to recovery, she's also picked up how we respond and get the trust back on track, along with Simon, our new CFO, in terms of our finances. So in summary, it's not a good story to tell, as you well know. But I suppose where we are now is we're predicting break even at the end of this financial year, and we are pulling out all the stops we possibly can in order to try and turn the situation around.
Thanks, Mark. So if I just now take you through what are the key actions that we've done, and then open it up for questions, because I think that would be really helpful. So as Mark says, we are now in financial special measures, and that is probably the most severe penalty that an organisation can have. And whilst Mark talks about those positive elements of it, and there are positive elements because they come in with that improvement programme as well as the regulator stick, it is extremely challenging. So we have, I personally have at least one, possibly two very heavy meetings a week. The trust is held to account monthly against all of its current performance targets. We have a robust performance recovery plan based on some key, let's be really honest, because this is such a technical, this elements of this are very technical. And so some of the recovery programme has been around making sure the transactional technical adjustments are put in place and the policies and procedures to stop this happening again have been put in place. So this first 6 months have been very much around those transactional elements of improvement. The next 6 months are very much around the cultural elements of improvement. So we have an external finance improvement director that works alongside us. He and his team, because there are a number of them, work very closely with us, holding us to account regularly at all meetings. We have our new senior team in finance have gone through a number of iterations of training. They have strengthened their own governance quite considerably. There has been a huge amount of policy changes within the finance department to ensure there is rigour. So that key question, could this happen again? As it stands at the moment, absolutely not, because those triggers have been put in place. We've got new reporting lines, so to ensure that actually from a reporting point of view, that the truth of the situation cannot be hidden in a report. It's very transparent, very open reporting, and that's board-to-board reporting. We've got much stronger grip and control programmes in place. We have a financial recovery board that sits every 2 weeks, and every pound of additional spend is questioned during that meeting to ensure that we absolutely reduce our run rate going forward. We can see those real green shoots of improvement there. And as Mark said, this year with the COVID funding, which is very different, I know, but we are going to end the year in the surplus, but it does put us in a good position for next year. We have had a very robust cost improvement programme that has also been running alongside us, and we have exceeded the achievements there. The training programmes are really important, and this next 6 months is very much looking at the training, again, board towards. So the board is going through a very robust and rigorous training programme individually and as a team. And again, that is externally facilitated and answerable to NHSR, we're regulated through that process as well. But the training programme will affect all budget holders in the organisation, because that cultural piece, that cultural change that we need to ensure that we embed will take, at least another 6 months to put in place. We're hoping that our financial special measures will only last 12 months, but I think we have to be prepared for it may going over to 18 months, purely because we've got to make sure we write not only our future, but this team and Simon and his wonderful deputy are also having to write the history of not just 1 year. So they are working through a programme with our external auditors to ensure that we're able to sign off our accounts in August for 1920 and 2021. So there is some history stuff that is being done by our teams, as well as that future piece. I will stop there because I think it is important that we answer the questions. Thank you, Chair.
Come off. There we go. It takes time for this thing to unmute. Thank you very much indeed, both Mark and Rebecca. Sarah Hill.
Thank you, Chair. I'm disappointed, actually, Mark and Rebecca have had to face up this, because I think the board really should have been here to answer for it. That's disappointing. I have read the original audit report, and quite frankly, if I was on that board, I would have been absolutely horrified. I just couldn't believe it. And I think things were left to roll for too long. I mean, I can remember a zillion years ago, John Adler coming and telling us how they were going to save 40 million a year. Various big schemes. You remember that, I think, Kevin. And it kind of disappeared and died a death. And I think I can see where it went, if you see where I mean, the initiative. And I'm just disappointed, really. The lack of transparency. But I suppose now you've had the drains up, it'll get sorted out. But it's a shame it had to come to this. It's just disappointing that it came to this.
Yeah. And I share that disappointment.
Yeah.
You know, I think this is a situation that nobody wants to be a part of, or even part of the solution, because it is a very painful process.
Yeah.
And we know it is a process that unfortunately has been in the making over a few years. And I think I might just bring in Simon, if that would be helpful here, because, you know, he was so instrumental into helping us discover the scale of what there's a situation, but also more importantly that real recovery piece. Simon, are you happy to come in here?
Can I just sort of, before you start, just finally say I do think that, unusually for me, Kevin will be amused by this, that I'm in complete agreement with the leader of Harbour District Council, that I think all the members of the board really need to consider their position, because you know, they've let it get to a pitch it shouldn't do. Anyway, I'll let you carry on, Simon.
Simon?
Yeah, there he goes. Yeah.
Okay, thank you. Can you hear me?
Yeah.
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 Just to add, in terms of the board, we've also got 2 new associate directors now with very strong backgrounds as qualified accountants. So the finance strength of the board is quite considerable now, which it obviously clearly didn't have the right technical expertise on the board in enough substance before. So I think it's important to point out that, you know, in investigating the balance sheet, I had myself and a small cell, if you like, of very highly able and qualified technical accountants who were able to quite quickly find a whole range of technical errors in the accounts. And we talk about the balance sheet, but of course the balance sheet of an organisation is its cumulative financial performance. So, as you all know, it gives the assets and liabilities of an organisation. And if you like, once you lose the integrity of that balance sheet, you never get a clean start. You can't just say, well, it's the new financial year, time starts again. I think you all understand that until you can actually get an accurate statement of the assets and liabilities of an organisation, you've kind of lost the audit trail of the accounting records, and that's what we've had to re-establish. And I'm confident by the end of August, the board will have accounts which it can approve on the 2nd of September. But in order to correct all of those technical accounting adjustments, it's taken an enormous amount of work, because there's a big range of them. So there's everything from, for example, things that were accounted for as prepayments, in other words, relating to a future period when they didn't really relate to a future period. Things like missing accruals, which is where you've received services in the current period and the invoice hasn't arrived yet, but you should account for the expenditure in the current period, but that didn't happen. Even more technical things around particular provisions that have to be in the accounts in accordance with accounting standards, which were in there but were not at the right values. The provisions were too low and not in accordance with the accounting rule book, if you like. Things like stock which was valued too high, asset lives on equipment which were too long, and so on and so forth. So and a whole range of technical accounting issues that I think would have been quite difficult for any non-finance people on any board to have actually uncovered, and indeed the external auditors gave a clean audit report. So I mean, I do have to say, and maybe I shouldn't, but the exec team I'm working with at the moment is one of the strongest I've ever worked with, and I've been at Nottingham. I was at Oxford for 11 years. You know, I was at Brompton and Hereford. I've been in some of the most prestigious NHS organisations in the country. And I'm not at all sure that those individuals would have spotted what was going on here either, because unless you're a qualified accountant, it's really quite difficult to see through it. And, you know, that's where you have qualified accountants, because of that professional integrity and because of their competence and understanding in technical matters. So you do have to rely on that to some extent, however good your governance is.
That's very, very helpful. Thank you very much.
Just quickly come back, Chair. I think, you know, the auditor's report, the auditors knew something was going on, didn't they?
Yes.
And it said in that auditor's report, every time they raised it, the board sided with their own accountants. That bothered me. Because normally, the auditors are there to be that professional advice, and it was ignored, and then it was too slow, the response, I guess. So yeah, that's where I was coming from with my concerns, that the auditors said there was a problem, and they just sort of ignored it. I've seen auditors disagree about technical, how something's written down on the books, whether it should be category A or category B. But from what you've just said, it was more systemic and more concerning, and that was kind of seen on the edges of it, but then ignored. Thank you, Chair.
Yeah, thanks very much, Sarah. Yeah,
can I just come back on that, Sarah? Just because, whilst I understand, and I absolutely, I can understand, and I am fully taking responsibility alongside every single member of the board that is left currently. I think it was not ignored. There was not an ignoring of an issue. Once the issue was raised, there was an actions were put in place, and we had, and then maybe the issue is that we took the assumption, but we absolutely put our faith that our teams our financial teams were dealing with the aspects that were raised by the auditor. The issue was they weren't, and then when that was raised, once we raised that and said, look, these have not been raised and we need to get to the bottom of it, Simon was in and he was able to expose that. So as soon as we saw what this situation, we were very, very transparent with that. We came here in January, we were straight up to the NHSIE over it. You know, nationally, they were all over this situation. The only thing we could do was just say, this is the situation we're facing. We will do everything we can to support it, to get it in the right position. And that is what we focused on. And of course, people have left in the meantime. And so people have been held to account. And what I would say for those people involved, so for myself and the executive team and the board that are currently left, the NEDs that are currently left, we are performance managed on this very, 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 very closely. It would be easier in some respects. People could have walked away. And I think from an executive team, I am so very proud that everybody stuck together and put all of their energy and effort into this, as well as managing a pandemic, as well as smiling and ensuring every day that our staff were, felt that they were being supported. So I understand your disappointment. I understand that you felt it was ignored, but both those words, are things that we have really questioned ourselves a lot about.
Yeah, thank you very much for that, Rebecca. I see Andy Williams has put his hand up. Is there anything you want to add at this point, or is it just a generic bit, Andy?
Well, it was really just to thank you, Chair. It was just really to come in almost to echo what, in fact, Rebecca has just said, which is, when something like this happens, there's clearly a desire to hold to account. And I think that has happened, actually, and Rebecca's described the changes. But there's also a very important need to fix the problem and to kind of, to move forward. And I think from a system point of view, from a wider kind of perspective, the right balance has been struck, actually, between dealing with issues of performance and making changes, but also providing sufficient continuity of leadership to give us a realistic chance to move forward and address these issues. And although obviously the focus understandably today is on UHL, we are working together on this. UHL are a valued partner in the system. The team, Rebecca personally and the team leading on this, have been extremely transparent with partners. And we're all committed to kind of working and moving this forward. So, I just wanted to kind of offer that context, really, Chairman, and support to say, I think there's a good degree of confidence in Simon, in Rebecca and the team now to rectify this issue and move forward. And that's what we're all committed to doing.
Thank you very much for that, Andy. That's very helpful. Samantha, or Sam. Very posh.
Thanks, Chair. I'll start by saying, obviously, I don't come from a financial background, so I am looking at this through the eyes of a layperson, and I would also say possibly like a lot of our members of the public, and I was deeply concerned in, I think it was July it came to us originally, although last year just seemed to be one total March. So I'm not sure, but I think it was July. And I obviously, when we came away in July with our deep concerns over what was happening, we understood that certain things would happen. And now this report has come back to us, and we don't appear to have had the things that we were promised in July, firstly, which, whilst I appreciate your moving forward to address all the issues, it was in July, it was highlighted the 18-19 issues and the 46 million, and then obviously that's been overtaken by not signing off 19-20, and then the papers that we've been given with today include the minutes of the audit committee, and I do note that both the important parts of that report that we could look at were confidential and therefore not included, so actually aren't much use to us to look at and to be able to scrutinise properly, because after all we are here to scrutinise. So my thinking is there some mechanism where we can see those important confidential papers? Because as scrutinisers, we need to be able to do our role in this as well. So that would be my question, please.
Thanks, Samantha. So there's two things there. So one is around the issue that you were brought in July. Remember, this isn't a different issue, it's exactly the same one, but because 18-19 the prior year adjustment was found, it has meant that we've had to not be able to sign off 19-20 until that has been put right. So it is exactly the same issue that we came to before, but the consequences of it are much more clearer. That said, we've been working over the last 6 months to write those, and I am again taking, knowing rightly so, that we'll be coming back to the scrutiny committee to talk about those updates on a regular basis until we've signed off our accounts and we're in a position when we're not in financial special measures. So I would expect that and would want to do that and would welcome that, because I think one of the key things that I've had since going through this process this last week is there are also people out there that can also support us through this journey, through some sort of peer review, also with just sort of being that mirror facing us and helping us understand how we manage ourselves going forward as a partner. So there's some important lessons that we've learned. The audit committee notes that you've seen, remember, audit committee notes aren't normally seen, but we wanted to be very transparent and share those audit committee notes. The outstanding actions on those the only thing that you won't have are things which are absolutely that they have to there are certain rules that we are not allowed to share in public, and it's only those exact rules that we've had to keep privately, and that is very clear. And I can't remember what those rules are, but Simon might or Mark might be able to tell us. But things like, if it starts, money we're using other companies and things like that, and we can't share that information. If it's about individuals themselves, we cannot share that information. But that is the only thing that is not in those minutes. So we have absolutely been as transparent as we can be in this situation. I don't know if Simon, you wanted to add to that.
Yeah, there's some categories that you can't share. One is if it's commercially confidential. So you know, like lists of contracts that we've let and prices. Another one is if it's relates to particular individuals in the team and their conduct and, you know, outcomes from testing or interviews that the auditors have done that relate to particular individuals that might possibly be the subject of future investigation. And then a third category is where the report is very clearly not intended to be shared with any third parties, and the things from the last audit committee that were private, I can't actually remember exactly what they were, but they weren't significant. I mean, the whole story of what happened here is we've been very public about it, and the way it was described at the public board meeting on the 4th of February, in my view, is very comprehensive and very accurate.
Yeah. Yeah, I can agree with that. I listened to it. Yes, quite. Rosita.
Thank you, Chairman. I've been listening to all of this. I have read it all, and I think what I'm about to do is make a little bit of a statement, because I feel that at this particular point, we are where we are at. And this is what we need to use as a platform to go forward. Now, I agree with everything Councillor Hill said in the beginning. I'm disappointed. I also think that all of the executive, non-executive directors should have to go. And I feel there should be far more of a humble attitude rather than being defensive over this, because there was a blatant disrespect, in my opinion, for public money and the well-being of the public at large, because this loss affects the output of a health care system. But nevertheless, I also feel it's very that healthcare professionals are supposed to provide healthcare, and therefore the emphasis should have been on the accountants, the non-executive directors. And I'm not a professional, and I sit on bodies, but I would never ever not question, even so, or take the side just, you know, because the internal people, accountants have said so. But anyway, I don't want to waffle on, because it's not much point. What I'd like to see is, you're saying significant changes, there will be a lot of them, but what I would like to see, it is a really a strong governance in place, far more scrutiny of and broken down in simple, more realistic points, rather than a big thing where you can't get your head around. So the proof of the pudding is in the eating. Will these changes be good enough to address all of the issues? Will the future governance be good enough? And will this learning curve also be implemented across other services? Because it's really, really sad to be in this position in the first place. So I wonder whether we should, rather than looking backwards, to look forward. How can we ensure how this won't happen again? How can we all work together, not only to scrutinise accounts, but the effectiveness of governance in small size stages, so you know, that we can address it to improve and to make sure that the residents and the public money is looked after better going forward than after. So I guess my question is, in a way, how do we ensure that the significant changes that have been put into place will be good enough, and how will they be re-evaluated in stages? Thank you.
Thanks.
Would you like me to respond to that, Chair?
Please.
Yeah. So it's a really, really good point. So we, from a point of policy and process, we have made sure we put in place the right things immediately so it could not happen again, as in the technical adjustment side could not happen again. And I'm sure Simon could give you the detail of that. But I think what's probably is being asked is, can you have a more detailed plan of those actions, what has been done and what is future planned to be done in detail as we go through this journey together over the next 6 months, which I would be very happy to do. We're next week or the week after, we have to go to a national meeting where we will presenting the 6 month journey. So where have we got to against the plan? What has been achieved? What continues to be outstanding? What are the key actions for those next 6 months? So I'd be very happy to share with the scrutiny committee once that meeting has taken place, and that sort of detailed document could be made available, I'm sure, for the committee.
Thank you. Could you just repeat why? I've forgotten. It's just going, why not all of the executive, non-executive directors were let go? Because I think Mark was saying some of them, but some were kept for a reason. And it just sort of went over my head because, as I said, I agree with Dr. Hill and Councillor King. They all should have let go to, so could you just reiterate that point for me? Yeah. Thank you and good luck.
Yeah, so the non-exec directors all have different roles on the committee, on the board, and those all that were involved in decision making or leading from a financial point of view have either resigned or are no longer with the organisation. So actually those that are left are those that have taken a lead on other areas and areas where we have been extremely successful. So from a quality point of view, we go from strength to strength with what we do from a quality point of view, from an IT point of view, from a performance point of view. So those members of the non-executive team remain, but those involved with the finances have gone. Plus, we've added 2 additional finance associate directors on the board to support all the NEDs because they will have that extra experience of finance. They're all qualified accountants, and our new audit chair, Mike Williams, is an absolute one of the most experienced people that I've had the opportunity to work with. He is absolutely wonderful, Mike Williams, and he's now our audit chair. He is an eminent accountant, but he is also somebody who's worked in public service and in business, and is really helping support us to change and be the board that we want to be.
Thank you. Chairman, I just thought of something. Now, with all of this negative publicity and with all of this going on when healthcare professionals really should be dealing with a pandemic, but in your learning curve, have you sort of recognized that this may be a good time to also evaluate the governance across other areas in order to focus on delivering healthcare rather than having to focus on administration and other things? So what I'm trying to say, has this sort of sunk in to apply better governance across the board?
I think as soon as there are concerns within any element of the governance, the first thing you do is look at what, is there anything else there? Is there something that we've missed in another area because our governance has not been strong? So that was one of the key things that we did, was actually just look at how we were managing, making our decisions. Could that be strengthened, not just for finance, but actually in all elements of the organisation? And we have done that. That said, what we are going to do, because we've got an external partner supporting us with our board development and training, we're going to ask that company to also support us with a review of our governance, just to say, is there anything else we could do to strengthen it? Because I think that external view on that would be really, really helpful. Because remember, we were absolutely reviewed. Our governance, particularly our quality governance, was absolutely scrutinised with the CQC, and we were able to support a good outcome, which was really exciting. But we know we cannot be complacent, so it's absolutely really important that we have a look at that, and that's the things that we're doing currently. But there has been changes, but we imagine there will be more. We've also got to remember we're having a new chair, and we will have a new chief executive, and as they come in and become part of this organisation, they will bring with it again their fresh eyes and their thoughts of what else that they would want to do to strengthen the governance situation.
Thank you very much. Good luck.
Thank you. Next one is Ted.
Marvellous, thank you. On page 80, the top paragraph header is Local Counter Fraud Specialist Report, and the specialist is from PwC. And you also have now UHL have appointed a counter fraud champion. At what point will the police be asked to intervene if PwC have a counter fraud person attending the meetings? And also, what does a counter fraud champion do? The next question is, are the allowances paid to the former chair of the trust and trust members, is that public knowledge? And also, monies paid to staff who've resigned as a result of this or prior to this being discovered, how public knowledge is that? And then finally, what cost is being incurred in actually extra staffing and rectification of this? And how is that being measured, and how public knowledge is that? Thank you.
Okay, quite a few questions there. So firstly, around the counter fraud. Now, just to be really clear and transparent, for the counter fraud teams were requested to look at this situation, and with the information that they held, they did not feel that there was a fraudulent issue around the 46 million. And I just want to be clear with that. The counter fraud specialist and the improvements we've made there, I'm going to bring Simon in, but I'll just bring him in a minute. Any payment for anyone on our board is public knowledge. It's released with our annual accounts and is open and transparent to all that see it. And the total cost to our improvements, of course, we won't know until the end of the journey. We are recording all of the cost to the improvements. Some of that is supported nationally. So one of the good things about going into financial special measures is that whilst it is very, very challenging, it does bring with it a large sum of money and real resource, real financial expertise to work alongside our teams. So that resource we've utilised, and we every person, any organisation going into financial special measures or quality special measures, whatever the area of concern is, they're all given the same amount of money. How you spend that money is very closely regulated by the national team. They help you design what you want to buy from that. So we brought our development programs, our training programs. We bought the additional support to help us do some of the transactional side that you see. And of course, they've also done some other things around the packages. Again, it's something that we could share that. I don't have it in front of me, but I'd be happy to talk you through that at another date. The total cost, of course, we won't know until the end of the year, so it might be something we schedule for the end of the time. That said, we've also got to remember some of it will be commercially sensitive because we've used external companies to support us, and they may not be happy for us to share all of that information. But we can show where the money has been spent. Can I bring in Simon, if that's okay, around the counter fraud specialist report?
Yeah. So just so everybody knows, that every hospital trust in the country will have a local counter fraud specialist, what's called an LCFS, and that service is something that every trust tenders out for. The people who provide that service for us are PwC. Sometimes it's big four firms, sometimes it's more niche specialist companies. And what they like to do is have a nominated counter fraud champion who is their point of contact within the trust team. And in our case, it's our Senior Deputy Director of Financial Services, Simon Linthwaite. And that gives them somebody they can contact about any fraud they're looking into. They obviously provide a service whereby they can be contacted by our staff if any fraud is suspected. And these local counter fraud services tend to look into routine fraud, which sadly goes on pretty well every trust. Things like, people bidding their expenses a little bit, or doing a little bit of timesheet fraud, or working while sick. And that is to make sure we deal with all of that effectively. Now, in the case of the 46 million prior year accounting adjustment, I think I'm at liberty to tell you that I did refer that to the National Counter Fraud Authority. And that was investigated by them, and they concluded that because nothing's been lost from the public purse, it's an accounting issue. It's not a case of anybody ran off with any money or anybody got any direct personal gain. It's a very bad case of poor accounting, but there's no loss to the public purse, and that's what they concluded. Of course, because it was such a potentially big issue, it was referred to the very top people in the country to look at that. And the conclusion they came to was, because there's no loss of money to the public purse, it's not a matter of fraud. It's a matter of potentially for professional accounting bodies to look at issues of competence and even professional ethics around the accounting, but it's not a fraud in the sense that the public purse has lost anything. I hope I've answered everything there, but if there's anything further, please tip me off and I'll answer.
No, you've answered that clearly. Thank you very much for your answers.
Yeah, thanks very much, Simon. I've got three more people want to ask questions. Gail next, then Amanda, Hack, and then Melissa. So Gail, you're on.
Thank you very much. Before I ask my questions or make my comments, I have to say I do understand this area a little bit. I did, prior to retirement, work for the Audit Commission, so it is something I have some familiarity with. I would like to say, first of all, that I agree with Sarah Hill that it's very disappointing that we didn't have board members here, because getting your systems right starts at the top, and the top is the board. And with the greatest respect to Rebecca, Mark and Simon, they are rather being left to carry the can when they personally weren't responsible, because they weren't the officers involved when this began, and they are not the board now. So I wanted to say that because I want that on record. And secondly, my main point is I do want to support what Sam Harvey said about our lack of information that we've got. I mean, last July, we were promised the Price Waterhouse report that the hospital had commissioned, but we haven't seen that. There are a lot of question marks in the papers here. You know, there's, for example, it says at one point in Annex 2, our Annex 2, consideration be given to seeking an internal review on whether the action plan measures resulting in tangible practice and culture changes. Well, the consideration may be given and nothing might happen. You know, no internal audit might happen. Well, that leaves questions. And I'm sure if we had had all the papers, all the confidential papers, it would have been considerably clearer for us. And I don't accept the argument that Simon's put forward that there are rules around confidentiality. Of course there are, and there are things that are commercially sensitive or personally sensitive that you wouldn't want in the public domain. But we as a scrutiny committee have in the past have had private meetings. Quite recently, in fact, last autumn we had one. Over the reconfiguration of the trust. And I would suggest that if we are to do our jobs properly as scrutineers, that we need to be given the full information, albeit if that means that we need to meet privately as councillors responsible for scrutinising this area. And I put that to you, Chairman, for your consideration, please. But I also want to say something else, and it's all very well, Simon talking about all these 2 new non-exec directors with accounting knowledge. Yes, that's good. It does help if you can understand a spreadsheet. Or in my case, if you could actually physically see a spreadsheet, it would help as well, for that matter. But actually, that is only a small part. Knowledge is important, yes, an understanding of what you're looking at. But if you are going to be effective, you need to know what questions to ask, and you need to have the courage to ask them. And knowing what questions to ask isn't just about budget in this case. It's also about how people are working within the organisation to produce the papers in front of you. It's about what value for money they think they're getting out of it, and all those other peripheral things. And I hope in the training of the board members that these issues are fully explored. They appear to be covered. I've looked at the table that says what training is going to happen when, but what's written on paper and what happens in reality isn't always the same thing. So without any further information, I can only go on what's on that piece of paper. And I do hope the skills of being a board member are also up front in the training of the new and existing board members. And finally, I hope in that training it's recognised, and board members are recognised, that even if you're not on the audit committee, that doesn't mean it's not your responsibility, because finance is everybody's responsibility. You can't do your job without resource, and the resource has to be managed well. And it's no good trying to fudge it, which I suspect was partly behind this in the first place, in order to appear to achieve something. Creative accounting, I think we used to call it. I have found holes in budgets when I used to work for the Commission, and for that very reason, where money was counted twice, and it actually doesn't help anybody. And it's not a question of blame. I'm not trying to blame anyone, and clearly some individuals have fallen on their swords in any case. But I am saying, if we are going to work together as a system to make it better, there has to be full disclosure for us, and the training of the board members going forward has to be robust. And whilst I fully recognise the very helpful and useful inputs you're having from outside, you're having externally, nevertheless, I don't think we want to keep hearing that everything's fine and everything's on track if it's not, and we haven't got the paperwork to identify where it's not. We would rather hear the truth and be able to support you in getting on track. Thank you.
Thanks, Gail. And let's that last point is really important.
Absolutely.
You know, one of the key things that you will hopefully have gained from the time we've been working together or been speaking, you know, in these last little while around the COVID, the vaccination and the other stuff that we've managed over these last sort of 10 months, you will hear the honest truth from what is happening. You will be able to, you know, I'm not going to sit here and say it's all okay, because it won't be okay. It's going to take us a long time to get where we need to be. And I think it's absolutely really important that we have to be honest with that, because that's the only way we will get to where we need to be. Just down some of those questions. So I hope I remember them all, but come back to me if I don't. First, around board members. Just to be clear, and it's important for the notes, both myself and Simon are both voting board members.
Quite.
Mark is also a board member. So we are part of the board. What we don't have here is any non-executive board members. And I think that might be the point that you were raising, Gail.
It was. My apologies for that, for not being explicit.
Yeah, okay, that's fine. The issue around information, whatever information we have, if it's not commercially sensitive or having an impact on individuals, I am very happy to go back and see what we can share. And I would be open to a private conversation if that would be helpful to people. And one of the things, you know, we could do quite quickly is have a look at that. But I also need, as we grow in confidence in our relationship, I hope you will realise if I'm saying I can't, it will be just for those reasons. It won't be for anything else. But as we go forward, I will try and make sure whatever we're looking at, particularly our 6 months review, because I think that will be a really important document for scrutiny, because this is where we are being held to account by our most senior regulators. So we're talking top of the shop here. In the NHS world, you know, a meeting that I have to say I'm extremely challenged about going to, but you know, it's part of the job. But I think having the ability to scrutinise that would be really helpful when we're able to share that. And we will go back and look what else we can share as and when it comes up, you know, around our development programme. Absolutely, you know, once things are happening and we're moving forward, again, you know, we have our board minutes, etc., which are in the public. I'm very happy to bring them here for further scrutiny if that would be helpful in any way. The questions about
sorry, it's not the minutes, it's the things that aren't in the public.
Sorry, I was talking around what's in the private minutes. If it doesn't meet those things, I'm very happy to work them through. And I will, Mark, myself and Simon and I will just have a look at the last lot of private minutes around the finance to see if we can maybe just those out so people can have the scrutiny of those. But again, it may be something we have to do in private, Gail, but very happy to look at that.
If that's what's needed, then that's absolutely fine. I'm sure the chairman would agree with that.
Yeah, absolutely.
Yeah. I think the other thing was making sure we're trained appropriately to do this right. And I mean, one of the key things is that the executive members, particularly the new executive members, come with a wealth of knowledge and expertise and are helping to shape the board with that. So it's not, I think there is absolutely the training program that will help us be stronger, but I think also having the new members coming and being part of the board helps us really reflect on our development and how we grow together as a team. So again, anything that we've got that will help you, I'm happy to share it as when it comes up, Gail.
Yeah, that's very helpful. Thank you very much, Rebecca.
Thank you.
So, Amanda.
Thank you, Chair. I think just to reiterate a couple of points that both Gail and Sarah have made with regards to detail. I think the covering paper, I would have anticipated a next step section, or where do we go? What's the reporting timeline? And it feels a little bit like there's not enough detail even in the covering notes in terms of what we as a scrutiny are looking to do with this paper. So I suppose that's sort of an initial commentary, really. I think one of the things that isn't really in here, and something maybe could be elaborated on, is having worked for an organisation that's had exactly the same experience in terms of being reported to the regulator, special measures, that kind of stuff. What was quite interesting about those processes is whether the culture was right in the lead team that's been managing this process. Now, I'm not referencing the current colleagues that have come today, because certainly you guys are mopping up the mess, which I think has been created by previous colleagues. But I suppose that you know, what kind of assurance can you give to us as scrutiny that the culture that enabled this to take place has been worked through and will be worked through in the future, and what steps need to be put in place, not only at board level but at 1 tier and 2 tier below, and what assurance can you give to us on that? And I think, you know, just if I can second Gail's point with regards to public domain meetings, we can go into private session, and I think it's really important that if there are things that can be shared at private session level, that we are encouraged to do that, because at the moment we can only scrutinise public domain information, which makes our job really, really hard.
Thanks very much, Amanda.
Yeah. Thank you. So just the culture piece. Now, I'm with you. To change a culture is not something you fix with changing a policy or a process. You know, that's transactional. That's the easy bit. That's the bit that you know you can do, and you can do in a short time frame. The difficult bit is to absolutely change a culture, and that is the key bit that we'll be doing over the next 6 months. So you know, bringing those cultural changes, strengthening the governance arrangements, being really clear on how you debate, discuss, question issues, that they're the bits, feeling that people have a voice when it comes to finance. They're the bits that will take some time, and I would welcome that scrutiny on that as we move forward. We will be putting together our, you know, we've done this in bite-sized chunks. As you can imagine, the scale of what we've had to deal with has been huge, and so what we've tried to do is put it into bite-sized chunks, and we've been supported by our finance improvement director in that aspect as well. So we are coming, you know, the bits that we've been able to do are the easier bits. As we move to this next section, we, you know, be very happy to share with you that programme, and again to have that critical review of that will be really helpful. Really helpful. But it's not something we're going to do quickly, and one of the key things around being in financial special measures, everybody rushes to get out, but we as an exec board have said, actually, we're not going to rush to get out. We're going to rush to solve the problem, and if that takes longer because culturally, you know, we need to do something here which is big, then it takes longer. And we just be honest and open about that. And that's why I said very clearly when I started, you know, we would like it to be a 12-month programme, but I think we're looking at a longer 18-month plus programme here.
Thanks very much, Rebecca. Very helpful. Mark, I see you've got your hand up. Do you want to come in at this point?
If I may, please, Chair, I'm going to just caveat this with it might seem defensive, but I don't mean it to be. And it's about this issue of culture. I'm really very keen that people do not brand these hospitals as having a rotten culture, because remembering that we've got 16,500 staff who, frankly, are doing things that I think are kind of humbling and brilliant and beautiful on a daily basis. And that's not just the front line, it's people across the whole bloody trust are like that. They have been let down, I think, by a small number of individuals. And as this individual, I think culture starts with the individual. And I've reflected a lot, as you'll probably expect in recent months, about what I could have done differently. And there's a real funny balance between trusting your colleagues. And at the moment in a pandemic, when it's a bit like being at war working in the NHS, you spend so much time with people that you have no choice other than to trust people, because actually you couldn't do the job without it. And I think the balance we're going to strike, and Rebecca and Simon and I and others have been talking about this a lot recently, is how you maintain that camaraderie without losing your curiousness in terms of making sure that you ask the right questions. But my point is, please don't think that there's something rotten in the heart of UHL, because actually there's lots of brilliant stuff this place does on a daily basis that will never get covered.
Yeah.
This is a very specific issue, and I don't want it to contaminate all the rest of what we do, please.
No, thanks,
Rebecca. Yeah, it's a really important point, Mark. You know, let's look at our COVID journey. You know, we have been in the best position. Our outcomes have been some of the best in the country. Our research is international, nationally recognised. That if we couldn't, you know, that's just a very small example. If we were not had a culture that really was a very positive and forward thinking, we wouldn't have been able to do those things.
Yeah.
In finance, we have let ourselves down, and we have now got to get the same position as we are from a quality point of view into our finance.
Yeah, thank you very much. Now, a while ago, earlier in this meeting, I actually wrote on my bit of paper here and circled it and underlined it, trust. And exactly what Mark was saying. After a while, you do trust people you work with, and you trust that they're doing their job the right way. And it looks like here, that's what happened in the finance department. They let you down, basically. They let everyone down. And finally, Melissa, who's now had a real humdinger, haven't you, of a 2 days, 3 days on all this. Yeah.
At least my children aren't here today. And I'm sure Mark and Rebecca are bored of my questions on this issue. I think what's hung around in my head since our meeting on Wednesday, and I'm not sure if I'm being daft or naive or just missing something completely here. I'm just not at all clear as to why this has happened. And so whilst it strikes me that there's clearly misconduct and negligence, and as you've explained, and that has seen actions and consequences, and as Simon has explained, there's no evidence of material gain. So I'm just stuck as to why. So my question is this a case of austerity, asking people to do the impossible for too long? And if so, is it possible there are other similar issues in other trusts nationally?
Big question.
It's a big question. That is a big question. So,
and apologies, Rebecca, I appreciate you can't speak on behalf of those other trusts, but it's just amusing as to how we've got to the place where and why we were so keen to present such breezy, factually dubious accounts, creative accounts.
So again, what we can't do is talk for those people who were involved in that. You know, why did they do that? You know, of course, it's a question that we have all asked. You know, why did they not trust us with this information? Yeah. Why did they do that?
Yeah.
Now, I can't answer that question, but I do know that every organisation in any public service are under a lot of challenge to manage financially in any situation. There's very few public services who are sitting with loads and loads of money. That said, there are very, very strict rules in public service. So I cannot tell you or answer why would somebody do something which is not professionally appropriate with public money. I don't know.
No.
You know, and that is the truth. I'm going to ask Simon and Mark to come in, but my view is I don't know why. I don't know why. Mark?
Why is it always the last question's the hardest? I don't know why. I don't know why either. But Melissa, if underpinning your question is there a tremendous amount of pressure on NHS finances? Yes, but we don't have a monopoly on that, do we? You know, I prefer to be in the NHS than adult social care, as an example. Does that in any way excuse or explain or mitigate what took place? No, I don't think it does. If that's where you were going with it, I think the job of anybody who's involved professionally in this organisation or any other is to take that pressure and deal with it. Otherwise, don't do the job.
Yeah.
That wasn't, sorry, Chair. That really wasn't where I was going with this. My question, which the bit maybe it got lost in what I was trying to say. So my question for all of us is this the case of austerity asking people to do the impossible for too long, and if so, is it possible there are other similar issues elsewhere in NHS trusts nationally? So that is the question as read, and I'm, you know, again, not necessarily looking for it to be answered here, but yeah.
Yeah, quite. Yeah, big question again, as we said. I thought we'd ended, but no, Samantha. Sam.
Sorry, Chair. I just with what Rebecca and Mark have just said, and I just think for the members of the public that will be listening to this, I might have some concerns. I know I asked this before, and Mark in the last meeting in July, and Mark replied a particular way, but I'd like to ask him again, really, and I'll probably ask again in the future. And it's just with regard to the these accountancy issues and the obviously whether they would have any bearing on the reconfiguration money. Now in July you reassured us on this matter, so it's just really to seek your views on reassurance further. Thank you.
I will give you the same answer, and in one sense, thank you for asking it, because it's kind of the elephant in the room, isn't it? Yeah. We have had no sense from any of the people we deal with, and bearing in mind what Rebecca has been saying, we are in constant contact with what Rebecca described as top of the house, top of the shop, to say that the capital investment in Leicester's hospitals has been jeopardised by this. I suppose, if we're being a pragmatist, not least maybe because actually part of the solution to our structural deficit, with the accent on the structural element of it, is that by reconfiguring the hospitals, actually we do save money in the long run, and that money therefore gets, you know, freed up to be reinvested into local health services. So no is the answer, but you know, I have to caveat it, as I'm sure Rebecca and Simon will want to, that you know, neither of us are on the board of NHS nationally, nor are we the Secretary of State for Health.
Yeah, quite. Yeah, just to say, actually, of course, having listened into the City discussion on this on Wednesday, same question got asked by the chairman right at the end as well. So it's and the answer's the same. That's good. Anything you want to say, Rebecca or Simon?
Yeah, I was just going to just add that I think what we as an exec board are absolutely doing, along with our system colleagues, because I think our system is absolutely helping us with this, is making sure that we're doing everything that we can to correct the situation so that it does not put any jeopardy on that 450 million. And that's really important, so that the energy and effort that we're putting into this, you know, is very, very high. We spend most of our days, you know, trying to really focus it, because we do not want there to be anything that gets in our way of our 450 million. And if you just think, you know, where we've been through a pandemic, we've been managing this financial challenge, but we've also had a very successful consultation process where we've reached, you know, tens of thousands of people, and we've been pushing and driving in the background everything that you would expect us to do. There are 8 hospitals who are currently being given this money, and we're working alongside those 8. We have regular meetings with the cabinet officer over it. So everything we can do, we are driving and pushing to make sure we do not fall behind at all with either our finances or our reconfiguration programme.
Yeah, thanks, Rebecca. That's very good. Thank you very much. Well, thank you, everybody. as I said, Melissa, you've done a fantastic job here, but sat through 2 of these. You're now the only representative from the city that came today, but obviously if they want to, they can obviously watch it all on the YouTube channel at a later date, like I had to for yours. And finally, the announcements I've got to make. One is to say that, and this may change, of course, bearing on circumstance what we've been talking about today, but theoretically, it will happen from May 21, so in a few months' time, the chairmanship of this committee passes on. Doorbell. Oh, 1 second. There's a man at the door. Oh no.
The joys of live.
Yes. I thought I might get away with that. Not quite. Sorry, yes.
It wasn't a dog.
No, it was the Royal Mail. I knew they were coming, but I was hoping they were coming in about 5 minutes. The chairmanship of the committee reverts back to the Leicester City Council. So Sarah, remember, this reverts every year or two. I forget what the rota bit is. So from May, the city and the administration then will be carried out by the city as well. So in theory, I'm saying that, unless another meeting is arranged in the meantime, the committee will be arranged by the city. And so Cal Sandu, who's their committee officer, will be making arrangements. Whether we're on Teams or Zoom, I have no idea, because by then we might even be meeting face to face. So that's where we are today. So thank you very much, all of you that attended.
Chairman, if so, may we thank you for your stewardship over the year, and thank you to all of the officers and everybody involved. So looking forward to a new administrative year, but thank you very much.
Some of the meetings went well, some didn't. Mark, you're about to say something.
I know it's not my place to say this, but I just wanted to echo Rosita's thanks, because it's been an extraordinary year for the NHS and for everybody around this table.
Yeah.
But these meetings have never felt anything other than well, if there's been fire, it's been calibrated in such a way that it's been respectful, and I know that we've had your support even in these extraordinary times, and I'm very grateful for that. And I know Rebecca and Simon are too, so thank you.
Yeah, no, thank you very much, everybody. No, I mean, we move forward, and let's make sure we make this still, keep it going to be, one of the best health economies in the country. That's what we can do, and we do that together even better. So that's the end of the meeting. Although, just for the members of the county council, the few of us at the left, just to remind you that on Monday afternoon, 4:30, we have a member briefing on mental health and how it's going in the area. So our obviously partnership in the partnership trust will be talking to us about what they do and how they do it, because a lot of people are very confused about just what